welcome everyone. And I'm Mahua Day. I'm one of the co-chair of this symposium, and it's my great pleasure to invite everyone to our 5th annual primary CNS malignancy. And this year we're focusing on pediatric brain tumor. It's not something most of us do every day, so we're very excited to learn from all the experts in the field. This symposium is a collaboration between Medical College of Wisconsin, ThedaCare, and University of Wisconsin-Madison. And my co-chair is Dr. Bovee. And then we have a committee that's made of Dr. Max Krukoff from MCW, Dr. Brent Morris from UW-Madison, and Dr. Pula from ThedaCare. With that, Dr. Bovee.
Thanks so much, Mahua, and thank you for all the attendees that have logged in. Thank you so much to our expert panelists that are going to provide us today an incredible program delving into the complex world of pediatric malignancies. It's hard to imagine this is our 5th year of doing this, and Dr. Day, Dr. Krukoff, Dr. Morris, Dr. Pula, and I are incredibly excited to be here with all of you today. This year's program, as Dr. Day had mentioned, is going to place a special emphasis on updates in pediatric CNS malignancies, reflecting the rapid progress in both our understanding and treatment of these complex diseases in really, truly a vulnerable patient population. Super honored to be co-hosting today with Dr. Day as we delve into emerging research, evolving therapeutic strategies, and collaborative efforts that are reshaping the landscape of pediatric neuro-oncology. And we really look forward to a day of dynamic discussion and shared insights that will hopefully help push our field forward and give us greater insight into these disease processes. With that, I think we'll just a couple of housekeeping things. During our presentations today, please don't hesitate to utilize the chat box in the lower right-hand corner of either your web browser or the WebEx app. Please post questions there that Dr. Day, Dr. Krukoff, Dr. Pula, and Dr. Morris and I will help moderate once we're done with the sessions, and we'll carry those over also into the joint sessions of all of the discussants at the end of each block for the morning and then the mid-morning sessions. We will go ahead and kick this conference off with an introduction by Dr. Krukoff. Good morning, Dr. Krukoff. How are you?
Good morning. Doing well.
Excellent. Yeah, if you would be so kind as to introduce our first speaker, that would be just great.
Absolutely. So good morning, everybody. It's my pleasure to introduce our first speaker, Dr. Paul Klimo. Very briefly, I'm Max Krukoff. I'm one of the brain tumor surgeons at the Medical College of Wisconsin. Dr. Paul Klimo Jr. earned his MD from MCW, Medical College of Wisconsin, then did neurosurgical residency and got a master's in public health at the University of Utah from 1999 to 2005. He then did fellowship in pediatric neurosurgery at Children's Hospital in Boston, affiliated with Harvard, and after which he entered active duty in the United States Air Force. During his 4 years of active duty, he was deployed in Afghanistan in support of Operation Enduring Freedom. He received an honorable discharge in July of 2010 as Lieutenant Colonel Select. Dr. Klimo joined the Sims Murphy Clinic in 2010 and currently serves as the Chief of Pediatric Neurosurgery at Le Bonheur Children's Hospital. So it's my great pleasure to introduce Dr. Klimo, and the floor is yours.
Thank you so much. It is a great honor to be here. Really enjoy this opportunity to talk to you guys. I'm going to share my screen. Okay, can everybody see that? Yep, great. Okay, so yes, good morning, everyone. Really an honor to be here and to give you an opportunity to think about various topics in pediatric neuro-oncology, neurosurgical oncology. So I was asked to give a talk on this topic, surgery for medulloblastoma, more controversial than you think. I don't have any disclosures. I thought we would start it off with a case presentation. And so this is a young girl that came to me a few years ago from India. She started having some headaches and neck pain. Then she started having some visual complaints. She had these visual complaints for a few months. It was eventually seen at a vision hospital because by that time her vision had really deteriorated and she had significant papilledema. So they ordered an MRI. This shows a large fourth ventricular mass, has some areas of enhancement, bad hydrocephalus, pretty severe transependymal flow, no spinal mets. So what they did was they put a shunt in first, then they did a resection, and fortunately she didn't have any postoperative complications. This is the shunt they put in. This is a little side note here. This is a Chabra shunt, so this is $35 compared to the $5,000 or $6,000 shunts we place over here in the U.S. So her pathology was medulloblastoma. It was a classic variant on histology, non-Wnt, non-sonic hedgehog. CSF cytology was negative, so she gets some repeat imaging. And this is what it shows. She has some residual tumor in this right cerebellomedullary angle. And so that's the question of the day that I'll be focusing. Should she be taken back for resection of this residual? And I have countless other examples. I'll just go through a few of them. This is a 4-year-old boy that came to me from Utah. So he has multifocal residual tumor, again in that cerebellomedullary angle. Also, as you can see here on the right, a little bit in the obex. This was a boy that came in from England. This was his original scan. So after the first resection, he was left with this fairly significant residual. And then they went back, and even after the second operation, he was still left with residual along the margins of the resection cavity as well as into this cerebellomedullary angle. So the dilemma of what to do with residual medulloblastoma, and then the more broader question, what is the impact of the extent of resection for medulloblastoma, continues to this day. So a few years ago, 2020, we had our PEDS neurosurgery section meeting, and I asked the question to the audience. I said, for this young girl that came to me from India with this residual tumor in the Luschka cerebellomedullary angle, what would you do? Would you reoperate? Would you proceed with adjuvant therapy? Not sure. And the results were quite interesting. It was pretty much straight down the line. 45% said reoperate, 46% said proceed with adjuvant therapy, and then there was a small 8% group that said not sure. So does extent of resection in medulloblastoma have an impact? And what about this 1.5 centimeter square rule? Does it even matter? Risk factors for medullo, so classic high risk factors that we all probably know: young age, less than 3, presence of metastatic disease, and then residual tumor more than 1.5 centimeters square. That's a number that's been floated around for a number of years. Additional high-risk features in the more modern era is LCA pathology, large cell anaplastic pathology, MYC or MYC-N amplification, TP53 mutation in the sonic hedgehog tumors. So let's go back a number of decades to this 1.5 centimeter square rule, because it still seems to be applied to this day. So it's been more than 25 years since the publication of the paper that started this 1.5 centimeter square rule. And like I said, some continue to implement this 1.5 centimeter square rule. So this is the paper, as best as I can tell. This is from February 96. So this was a paper in the Neurosurgery Journal, Effects of Medulloblastoma Resections on Outcome in Children. And this is the key graph. So this is probability, this is progression-free survival in patients greater than 3 with no metastatic disease with greater than or less than 1.5 centimeters square residual tumor. And you can see the separation of the curves. So that 1.5 centimeters square was really the value that was found by the stats team here at St. Jude after going through multiple numbers, and they found that that number, 1.5 centimeter, is what finally led to a separation of those progression-free survival curves. So there really was no a priori hypothesis. And you have to think back then, 80s, 90s, and even before, really extensive resection was all in large part based on CT scans. MRIs were becoming available, but certainly didn't have nearly the quality that we have today. And also a lot of times the extent of resection was based on the surgeon's operative report, and we know how inaccurate that can be. Well, since 96, a lot of things have happened. We now have intraoperative MRIs and a lot of intraoperative technology, better microscopes, IMRI to help us with resection. Of course, this is now the era of molecular neuropathology. So we now know that there are multiple subgroups in medulloblastoma, and now there are multiple subtypes, all of which makes me very confused. I have no idea what a lot of this stuff means. But at the end of the day, what we want is we want to cure these kids, but minimizing acute toxicity, whether it's surgery or non-surgery related, minimizing late effect problems, and of course, long-term disabilities. This is what we want to achieve. So I think the first attempt to really look into the extent of resection question in this molecular era was this paper that came out in 2016. And I have to give a lot of credit to Eric Thompson, a good friend of mine, to tackle this very difficult question. So in this paper that was published in Lancet, he had almost 800 medulloblastoma samples. He had the molecular results for all of them, and he tried to answer the question of extent of resection. And so he found that there was a progression-free survival for GTR versus subtotal resection, but there really was no significant benefit to gross total versus near total resection. When he looked at the various molecular subgroups, there wasn't any benefit to gross total resection versus subtotal resection. And this is where it gets a little bit funny. Except for the group 4 patients with metastatic disease, there seemed to be a benefit to having a gross total resection. So his conclusion was the following. Our findings in the study showed that there's no prognostic difference between GTR versus NTR, and should help convince surgeons to minimize morbidity when removing small residual portions of tumor. That's a fairly reasonable conclusion. So this is the forest plots of his study. So on the left is progression-free survival. On the right is overall survival. So when you look at STR versus GTR for overall survival, no difference. Yeah, there seemed to be a bit of a benefit with progression-free survival, but then there really was no benefit gross total resection versus near total resection. And then you get into the various molecular subgroups, and there seemed to be a benefit maybe in terms of age. Here is that kind of weird finding where gross total resection seemed to be a benefit for progression-free survival in group 4, but with metastatic disease. So a lot of it kind of didn't make much sense to me. So when I looked at this paper over and over again, I thought, okay, well, who was kind of the most critical contributors to the paper? So these are 35 centers, so there's a large number of surgeons of varying probably experience, capabilities. There was no centralized pathology review. Stats people, obviously, this is a very stats heavy paper. But in my mind, I thought that actually the neuroradiologist was the most important, and that's because they're the ones that determine the extent of resection. So in this paper, at each contributing institution, extent of resection was established based on surgeons' reports and confirmed on postoperative T1 weighted enhanced MRI, and less commonly, but not excluded, contrast enhanced CT. And so based on the post-op imaging, they've defined GTR as no residual, NTR as having less than 1.5 centimeters square, and subtotal as having more than 1.5 centimeters square. I'll be honest with you, even to this day, I find it difficult sometimes to measure 1.5 centimeters square. A lot of these medullos are difficult to image. They don't necessarily enhance with T1 weighted images. A lot of the residual tumor can be just bright on T2 or flare. So I think it's a little bit difficult, even in the best of hands nowadays, to get a black and white 1.5 centimeters square or not. Eric then followed up that 2016 paper with this one in 2018, which was a systematic review. And again, he's trying to answer the question, what is the impact of extent of resection for medullos? So he had a total of 50 papers that he included in this study. 16 articles showed some kind of benefit to extent of resection and survival. 20 papers did not, and 14 had mixed results. There were only 3 articles that accounted for molecular subgroups, and they did not show a benefit between extent of resection and overall survival. And these are, again, the forest plots from his paper. Again, on the left is progression-free survival. On the right is overall survival. So maybe there is a benefit in terms of progression-free survival, but really there is no benefit to overall survival. And if you look at the molecular subgroups here on the bottom, nothing in all the confidence interval, the wings on the forest plot, all of them cross 1, which means that there's no benefit to greater degree of resection. So then we get to this 2024 article, again in Lancet. So this is from the UK group. So they had 1,100, just over 1,100 patients, which came out of 2 populations. One was a UK cohort, and then there was this so-called MAGIC cohort. And they again looked at extent of resection. And they too found that subtotal resection did carry a worse survival, but only on univariate analysis. It did not pan out on multivariate analysis. And so their conclusion was, if you had subtotal resection and no other high-risk features, they are now recommending that these patients be considered standard risk, which is really kind of against everything that we do, at least here at St. Jude. These are some figures from that paper. So in the upper left here, you see just the overall survival curves, SDR versus GTR. So there is a statistically significant separation of the curves. This is when you take into account high risk versus standard risk. So blue line is the standard risk, red line is the high risk. Here is the subtotal resection group without any additional high-risk features. So there is no statistical difference between them and gross total resection with no additional high-risk features. So this is their kind of algorithm in terms of how they are now thinking about adjuvant therapy. So if you have subtotal resection, no other high-risk features, they are now considering these patients to be standard risk. So their conclusion was the following: findings from our study support the view that the primary goal of neurosurgical resection should continue to be maximal safe resection. The lack of independent prognostic significance supports the exclusion of STR as a standalone risk factor for high-risk treatment protocols and suggests treatment according to the presence of other identified high-risk features. So again, this goes totally against what we've been doing for all these years. So are we potentially turning the clock back? If we go to this kid from England, so this was a medulla large fourth ventricular tumor. So this kid actually had an IMRI guided resection done in England. This was the result after the first operation. All of this residual. In their new study, and with this study that they have already published, this is where they would stop. This is good enough for them. They would leave all of this residual tumor, and assuming there's no other high-risk features for this young boy, they would proceed with adjuvant therapy. So I counter that argument with what we've been doing, and I suspect that a lot of other centers in the US also kind of take our approach. We are very adamant, maybe more so than most centers, but we really strive to achieve either gross total resection or a near total resection. So this is our SJMB03 trial published in, I think, 2021, 2022. If you look on the right-hand column, so we had 330 patients. Yes, significantly less patients than that UK study. They had 1,100, but that was between two different cohorts. We only had 13 patients that had a subtotal resection. The vast majority of our patients achieve a gross total resection. 70 of them had a near total, but only 13 had a subtotal. So we have a very different philosophy. This is one of the tables in the UK paper. This is our paper here. So if you just look at the overall 5-year survival for their study, it's 67.6%, so about 70%. Our 5-year overall survival is was about 82, 85%. For average risk, it's up to almost 90%. So quite a big difference in terms of survival. So why would you not operate for residual disease? If we go back to that poll that I showed, about half of the audience would not operate for that child's residual tumor. Either you think there's no benefit to either progression-free or overall survival. You don't think that the patient can tolerate another surgery, and that's perfectly reasonable. There's no convincing residual tumor on the MRI. Maybe it's not safe to resect the residual. Maybe the more neurologic morbidity is too high. Maybe the kid's got metastatic disease, and so your rationale is, well, if it's metastatic, then there's really no point in going back in to take residual out from the primary site. Maybe you just don't have enough experience, or you lack the comfort to go back in. As I've stated, we take a pretty aggressive approach to a lot of embryonal tumors, in particular medullos. So about 25% to about 30, 35% of our medullos do end up going back for what we call a second look surgery. A lot of times the residual tumor is multifocal. And this was a paper that I put out a number of years ago. So where do we find residual tumor? Well, if you break up the fourth ventricle into 3 areas, you have your central part, which is the purple, you have your lateral recess, which is the blue, and you have the roof, which is the green. Most of the time, people are going to leave residual tumors off to the side or in the roof. And if it's in the roof, it's usually at the kind of the bottom deepest part of your resection, which is down in here. And we almost always find more tumor than we anticipate based on the preoperative MRI. And so what I often do when I take these kids back for surgery is I like to take notes, and I draw some pictures at the end of the case, more from my records, but I usually like to kind of record kind of where I find the residual tumor. And so this is a very typical location for residual tumor. It's in this, what I call cerebellomedullary angle. It's not quite the lateral recess. It's not quite the foramen of Luschka, but that's what a lot of the reports, MRI reports will say. But it's this little pocket that is right next to the brainstem and underneath the tonsil. So you have to know how to expose that area in order to resect it, because these little nooks and crannies around the fourth ventricle, they can hide tumor very effectively. This is the central part of your fourth ventricle. I've got some gel foam here. So this is the easy part to expose during surgery. It's these little pockets that are off to the side or in the roof up in there where it's more common to leave residual tumor. So, you know, this is an example. So I found tumor off to the side in this kid, up here in the roof. So here's a little nugget of residual tumor. So is the 1.5 centimeter square rule useful? At least for me, no. If there is any residual tumor and I feel we can take it out, we typically will offer that to the family. 1.5 centimeter square, it's an arbitrary value. It's got no kind of biological meaning. It's based on predominantly CT era. The newer data is highly questionable because of the methodology, like I was saying. And like I said, determining the degree of residual tumor can often be a little bit challenging, especially if there's hemostatic agents in the way, if there's blood products. And so I would say that if you're concerned about a reoperation, then I think that patient just needs to be handled by a team that sees this frequently, and at least for the surgeon, that surgeon is experienced going in and doing second look surgery. For us, if we're able to get that patient from a subtotal to either a GTR or a near total resection, that means there is de-escalation of adjuvant therapy. So my final thoughts about extent of resection. The source data for extent of resection is very murky. So we've got a systematic review. We have that original paper that collected 800 samples, but from like 35 or so centers. So you have many centers. The data is collected over many years. It's dependent on this 1.5 centimeter square rule. Subtotal resection is a very broad category. I mean, you're going from something more than 1.5 centimeters square anywhere to something a little bit more than a biopsy. So it's a very broad extent of residual tumor. But I would say that because the data is all over the place, it does call into question the role of achieving a gross total or near total resection in these patients. So far, the data seems to indicate that there is a benefit for more aggressive surgery with regards to progression-free survival, but mainly on univariate testing. That benefit does seem to go away on multivariate analysis, and there is no consistent benefit to any subgroup or any other or any molecular subgroup. So whether it's age, grade 3, grade 4, you saw on those papers that grade 4 with metastatic disease seemed to have a benefit. The UK group suggested that grade 3 seemed to have a benefit maybe, but only on univariate testing. So the data is really all over the place. So therefore, this topic of extent of resection remains controversial, and therefore you can use the data in either way. If you lean more towards the UK, the European, sure, you could say subtotal resection is good enough, or certainly even a near total resection is good enough. And you could argue that subtotal resection with no other high-risk features, that patient can be treated as standard risk. I don't think our approach is going to change much here at St. Jude. We've got really good survival data to support what we've been doing for a number of years. But I will clarify that with several statements. So you have to minimize surgical morbidity. If there is residual tumor and that residual tumor comes at a high cost, and I think you really have to pause and consider whether second look surgery is beneficial. There is a whole separate discussion on posterior fossa syndrome, and I think that, at least in some respects, is driving this subtotal resection in the UK. If you do a subtotal resection, the risk of getting a posterior fossa syndrome is significantly less than if you're trying to achieve a gross total or near total resection. I still think it's fine to get out what you can safely if you need to decompress the brainstem, try to reopen CSF pathways. And if there is residual, that's where the multidisciplinary discussion comes into play. We go through these patients in great detail and look to see if they are, if it's beneficial to take them back for a second look operation. What gives me pause for taking a kid back to surgery as a surgeon? Low risk tumor. So if it's a Wnt tumor, these kids do great no matter what. I rarely take a Wnt tumor back to the OR. If it's a neurologically high risk surgery, and by that, one of the areas that I really struggle with is tumor on the floor of the fourth, particularly in the region of facial colliculus. I hate giving young kids a facial paralysis. Metastatic disease does give me pause, and it really depends how is the kid doing clinically and what is the burden of their metastatic disease. So for one final case, this is a 6-year-old boy, no metastatic disease, large fourth ventricular medulla. This was how he looked on presentation. These are his areas of residual tumor. So he's got a focus on the floor of the fourth ventricle, but a fairly good chunk, again, out in that cerebellomedullary angle. I took him back. This was right on the facial colliculus. I left that alone. I resected this. So will we ever answer this question on the extended resection? No, because if you do a true randomized trial, you're going to require a lot of patients that is just simply not feasible. And Eric alluded to this in both of his publications, 6,400 patients for one trial, 3,300 patients in another trial. It's just not feasible. So with that, I thank you, and I give just a quick plug in. So this and other topics are going to be discussed. We have a tumor symposium later this year in September at St. Jude, and I invite anybody who's interested to come on down. Thank you.
No, thank you, Paul. That was just a wonderful talk. Lots of questions that I struggled with in my training with regard to that extensive resection, and I'm glad to hear you had the same. I do have some questions for you, but we'll hold that until the panel discussion at the end. Your upcoming conference looks amazing as well. So no worries about that shameless plug. I love it. I think it's fantastic. We'll see if we can get many of our attendees here to join the same. So just as a reminder to the folks who've joined, please use our chat function for questions. And Paul, thanks again for that great talk. That was just amazing.
Thank you.
Absolutely. The next discussant is Dr. Santi. Dr. Santi is a distinguished neuropathologist at Children's Hospital of Philadelphia and serves as a professor of pathology and laboratory medicine at University of Pennsylvania's School of Medicine. She specializes in pediatric brain tumors, developmental neuropathology, neurometabolic conditions, and neuromuscular diseases. At CHOP, Dr. Santi plays a pivotal role in the division of neuropathology, contributing her expertise to the Children's Brain Tumor Network and overseeing the screening and collection of cases referred by the neurosurgery department. Her research has significantly advanced the understanding of pediatric brain tumors and related neurologic conditions. And today she's going to discuss with us medulloblastoma with updates in the WHO 2021 classification with an emphasis on integration of molecular and histopathologic features. Dr. Santi, thank you so much for joining us, and sorry about the technical difficulties that you were having with your screen. I'm hopeful, and it looks like those have gotten resolved, but really looking forward to your talk.
So here the medulloblastoma. So already in 2016, the group of people that wrote the classification for the brain tumor realized that we need a different approach to the classification of brain tumor, integrating the molecular data together with the microscopic features. And this was a break from a century-old principle that was based entirely on the microscopic examination. Therefore, was suggested that when possible, the four-layer integrated diagnosis could be considered. In 2021, regarding the medulloblastoma, there have been some refine. As most of you knows, the medulloblastoma are defined genetically and histologically. However, one thing that has to be clear is that the intention is for an integrated approach with the diagnosis listing both the molecular and the morphological pattern. Of course, the WHO is written for people, all pathology all around the world, and there are places in which the tumor cannot be genetically defined, but in United States, in the Western county, this is what the clinician expect from the pathologist. The medulloblastoma is a malignant invasive embryonal tumor. I would like to remember, since it's 100 years, that Bailey and Cushing gave to this tumor the name exactly 100 years ago. And why? Because they thought that cytologically the cells had the similarity with the feature of a presumed medulloblast in the embryonic medullary velum. These cells has never been identified, but the name is still used and was never changed for historical reason. Is the second most common malignant CNS tumor in children after the high-grade glioma, 20% of the intracranial tumors, with a median age diagnosis of 9 years. Two peaks, 3 and 10 years of age, can be present in young adults that now we define as the population between 21 and 40. Much more improbable to see that type of tumor in older patients. And approximately 65% are male. The clinical presentation know very well the increase in intracranial pressure for obstructive hydrocephalus, truncal ataxia, and in infant, the increased head circumference may be the presenting sign when the bones are still very soft. Backache, avoiding difficulties in tumor that disseminate to the spinal cord. And the previous talk, I've shown you several different imaging of a medulloblastoma. This is the classical one, this large tumor, well circumscribed. And this is different from the high-grade glioma that have a more infiltrative type of pattern, heterogeneous, nothing really pathognomonic from an MRI point of view to define the presence of medulloblastoma with certainty. However, the good neuroradiology can tell you that this is a medulloblastoma pretty precisely. When a medulloblastoma is diagnosed, a completely spinal cord MRI, at least in our institution, is done because we know that this tumor tends to spread throughout the subarachnoid space with the sugar coating carpet-like or enhancing nodule type of features. Very rare today is to see a medulloblastoma at autopsy and diagnose only at time of autopsy. And you can see basically that these tumors are characterized, can have this different aspects such as a gritty appearance, with some area of necrosis. In older children, it is interesting to see that the tumor can occupy the cerebellar hemisphere. So instead of being midline from the vermis, cerebellar hemisphere. Hemorrhages can be present but are not that frequent. This day we see this tumor mainly as a biopsy that we received. This is a classical example of the sugar coding spreading of the tumor throughout the CSF. You can see here the entire cerebellum covered by this grayish subarachnoid infiltration. This is a nodule of tumors, and this tumor spread to the base of the brain as well. From a histopathological point of view, we recognize 4 distinct entities. We have the classic, the desmoplastic nodular, extensive nodularity, and the anaplastic large cells. We will go back to the extensive nodularity next slides. Starting, however, with the classic, that is the most frequent type of pathology that we see, is composed of small, round or ellipsoid carrot-shaped cells, I-NC ratio, and here you can see on the right a tumor with on the right rosette. These rosettes are present only in 40% of the cases and are not the sine qua non to make the pathological diagnosis. Most of the time, we see this absence of any specific pattern and with this back-to-back carrot-shaped cells. Mitosis are frequent, however, the pseudopalisating necrosis of the microvascular proliferation, so characteristic of high-grade glioma, is not prominent. A pattern can be variable with these cells organized in file when the tumor invaded the meninge and became desmoplastic. This tumor have all of them needs to have a certain grade of neuronal differentiation. And this is an example of staining with the synaptophysing, with the neurofilament. GFIP in reality stain only most frequently reactive cells rather than really tumor cells. However, if the embryonal tumor, the so-called round blue cell tumor of the cerebellum, the pathology is present with, is completely negative for the neuronal marker, I would be very careful in putting forward a diagnosis of a medulloblastoma. The nodular desmoplastic is really classic biphasic with the internodular area rich in reticulin and the nodule that has a poor amount of reticulin. Basically, the nodule is a manifestation of a neuronal differentiation. So the internodular area is densely packed, highly proliferative cells, hyperchromatic nuclei, really high level of mitotic figures as present here on the bottom left. The nodule in the center, poor amount of reticulin, not much reticulin. Then we have cells with some grade of neurocytic differentiation, sometimes even ganglion cells, strongly positive for synaptophysin. There is then a rare tumor that is the medulloblastoma with the extensive nodularity. Basically, is a tumor that biologically mature toward a more neurocytic and less embryonal and primitive appearance. This is why this type of tumor, when in patient less than 3 years of age, without other type of element, is considered a good prognosis. Unfortunately, this type of tumor is not that frequent. The worst possible pathological appearance is the large cell anaplastic. In the past, these two tumors were separated, these two types of morphology. Now they are put together and they are characterized by marked nuclear pleomorphism. As you can see here, the nuclear molding, cell-cell wrapping, high mitotic activity. there are this intense apoptotic activity with all the apoptotic cells that coalesce together to create the apoptotic lake. And this is present in large cells anaplastic and not in other type of classic tumor. The large cells need to show this prominent nucleoli, some amount of eosinophilic cytoplasm, and again, numerous mitotic activity. Large cells anaplastic, both together. Sometimes a certain amount of anaplasia is present even in a classical tumor, but in order to call the tumor large cells anaplastic, the large majority needs to have this appearance. And of course, the large cells anaplastic may trigger the problem of the differential diagnosis with the tumor that I show here on the right bottom. That is in reality an atypical teratoid rhabdoid tumor that is another high-grade tumor of the cerebellum, cerebellar pontine angle. It's not difficult, the differential diagnosis, because this tumor demonstrates a loss of the INI1 staining due to the deletion of the tumor suppressor gene SMARCB1 on chromosome 22. The profiling of the medulloblastoma started from the expression-based analysis in 2006, and in 2012, finally a consensus between European group and North American was reached, with this very famous paper on acta neuropathologica that divided the Wnt from the sonic from the group 3 and the group 4. Each one of this group has some preference regarding the demographic, slightly different clinical features and pathological feature, and difference in genetic and prognosis. From this, you can immediately see that the best actor, the lower the tumor that can do better is the Wnt. And the tumor that is the more, as the less good prognosis is the group 3, with the sonic shock and the group 4 altogether. Remember that when this paper was published, there was no separation between the sonic p53 mutant or p53 wild type. In infant, there is no Wnt tumor, and the Wnt tumor is the most frequent seen in a young adult. And it seems that in young adult, it does worse than in children. And this is basically a summary of the characteristic of all this tumor. The most frequent in reality is group 4, with, as we know, a prognosis that is intermediate, a pathological appearance that could be classic of large cells. In the Wnt case, large cells morphology is rare, and the sonic shock is frequently associated with the desmoplastic nodular. So there is a disassociation between desmoplastic nodular and sonic shock. And of course, the extensive nodularity is of the sonic shock type of tumor. So if it is so important to define the group in order to decide upon the therapy, what the pathology can do in order to determine the subgroup. There are different approaches, and I will rapidly go through all of them. Immunohistochemistry, as you know, everything started with the paper from St. Jude published by Dr. David Ellison, using 4 different antibodies, and we can say 3 because we can eliminate filamin A. You can differentiate the sonic, the Wnt from the sonic, from the non-Wnt, non-sonic. The Wnt subgroup is the best type prognostically, so you want to know if your tumor is a Wnt subgroup. Interestingly enough, this tumor has a nuclear staining for beta-catenin. Oh, now here what I present is an exaggerated type of nuclear beta-catenin. Normally, only few cells have this intense nuclear staining. No, and is not easy to identify the nuclear staining because all the medulloblastoma have anyway a cytoplasmic staining. So we use LEF, another immunostaining, in order that is positive and is much easier to read in comparison to beta-catenin. These tumors are positive for filamin, positive for YAP, but negative for GAB. The sonic hedgehog, in contrary, has a cytoplasmic beta-catenin, and filamin is strongly positive, mainly in the internodular area. YAP and GAB are both positive. Then we enter non-Wnt, non-sonic subgroup. This tumor have a cytoplasmic beta-catenin, negative filament, negative YAP, and negative GAB1. And this is another non-Wnt, non-sonic with a lot of on-the-right rosette that, however, for the subgrouping does not add anything. So with immunostaining, and here there is a very nice summary, we can distinguish three different subgroups. And these are the so-called immunostaining that help and can give you information that is the surrogate molecular type of staining. However, we cannot separate group 3 from group 4. How to solve this problem? There are a different approach and probably more than one need to be used. Remember that many hospitals, mainly adult hospitals, use only the immunostaining because offer a cost-effective method, works very well on paraffin fixed tissue, and offer some interesting information. We, of course, as a children's hospital, wanted to give the completely subgrouping. Can we use the SNP array? It does not solve completely the subgrouping because monosomy 6 is present in 86% of the Wnt, but is not completely pathognomonic for the Wnt. And all the other features that you can pick up with the SNP array are enrichment, but are not specific. It is important to know about the MIC and the MICAN amplification. Of course it is. And this can be done with fish like St. Jude does, and not necessarily with the SNP array. But all the other features, such as isochromosome 17, does not separate group 3 from group 4. Next generation sequence is what we do at CHOP because it offers us the copy number variation plus some information regarding gene mutation. But again, is not helpful for subgrouping. However, gave us information about the T53 mutation, so important for the sonic hedgehog, and give us the possibility to identify the germline predisposition gene that are present in 14, 15, in more or less 20% of the sonic hedgehog tumor. Mutation of the PTCH1, SUF, SMO, APC. Sick kids in Toronto, they use the nanostring to subdivide the medulloblastoma. This is an RNA-based technique with a good concordance with the expression-based subgrouping. And yes, it is separate the 4 subgrouping. However, there is a problem. If you are not completely sure that that tumor is a medulloblastoma, it can generate error and mistake because it would put the tumor in one of the 4 categories, even if the tumor is not a medulloblastoma. The best system is definitely DNA methylation that has a concordance with the expression-based subgrouping of 95% and divide Wnt, sonic, group 3, and group 4. that has a complex bioinformatic, is more expensive than the other technique, and has a turnaround time around 2 to 3 weeks, at least at Children's Hospital of Philadelphia or NIH. So let's relook at this case. The Wnt activated good prognosis can be present in young adult. Monosomy 6, remember, large majority, but not all of them. Mutation of the CTNNV1 gene, this is responsible of the immunostaining with beta-catenin that is nuclear. When the tumor is a Wnt activated by methylation, but does not have the CTNNV1 mutation, please consider the APC germline. The familia adenomatoso polyposi is a risk factor for this type of medulloblastoma. Sonic shock activated. 20% of the patients have the germline cancer predisposition mutation with the mutation of the PTCH1 gene, the famous Gorlin syndrome or nevoid basal cell carcinoma. We need to know about the T53 mutation. And yes, of course, we can do with the antibody. But the 3 cases that I presented here are equivocal. Sparse cells that are weakly positive. In our end, this type of staining were all basically read as negative. There was no mutation of the gene. Therefore, considering the importance of knowing the characteristic of the T53 status, some DNA analysis needs, in our opinion, to be done. The sonic shock, however, can have a poor prognosis even if T53 wild type, if there is a MECAN amplification, GLI2 amplification, metastatic disease presentation, or 14q loss. And again, we have a very good prognosis in the children less than 3 years of age with the extensive nodularity. When the tumor presents in very young children, the consideration of a germline mutation has to be kept in mind. And here you have instead on the bottom right, the strongly positivity with the P53 antibody in a sonic activated P53 mutant. And you can see the difference in prognosis of this type of medulloblastoma, mutation or not mutation. Interestingly enough, this type of tumor, rather than the nodular desmoplastic type of morphology, is large cells anaplastic. The type 3 tumor is the tumor with the worst prognosis if we, for the moment, forget about the T53 sonic shock. The methylation in reality, as we heard before, separate many different other groups, but we do not know what is the clinical relevance at this moment. What is important to know is if there is the MYC amplification that is an important cytogenetic prognostic marker. Group 4 is the most frequent type of tumor that we see, and again, the methylation may separate alpha, beta, and gamma. But we report that, but we do not know what is the clinical relevance of that. Of course, as repeated many times, the presence of metastasis presentation is put the patient in high risk. It appears that the loss of chromosome 11 and the gain of chromosome 17 are favorable prognostic marker. And if you wanted to see the summary of what the methylation gives to you here. So we went from complicated to hyper-complicated situation. For the moment, we reported the subgroup, we report even the subtype, but I don't know if the clinician really used the subtype. This is the risk stratification that was published in 2016 on Acta Neuropathologica. And you see that in the high risk are considered beside the resection amount and how much of the tumor is left after the resection, the metastasis, the MECAN amplification, the MEC amplification, GLI1 amplification, and even the presence of the large cells anaplasia per se right now is a negative prognostic factor. So for the pathology, it's still important to use the H&E, look under the microscope, and not only based upon what all this molecular information can give you. When do we study the cancer predisposition? Mainly for Wnt and sonic. We need to consider the possibility of the familiar Gorlin syndrome and the APC syndrome. Much rare, I've seen the request of studying the PALB2 or BRCA gene for group 3 and group 4. The connection with cancer predisposition gene has been studied much more in detail for the Wnt and the sonic rather than group 3 and group 4. And this is a summary of the prognostic marker that I have presented so far. And basically the last slide is the minimal workup recommended for medulloblastoma when the WHO was published, considering that not everybody around the world can have available SNP rate, NGS, and methylation. So the staining are extremely important to be done, available to the large majority of the pathology, and together with the fish can give some very pretty exhaustive information. For the separation of group 3 and 4, either either the methylation. Here in America, we do now the methylation. So at the conclusion of this, I wanted to see here at Children's Hospital what happened when we have a medulloblastoma, and I send my final structural integrated report to my clinician. We listed in integrated diagnosis the type of tumor. As in this case, sonic shock activated TP53 wild type, then we list the histologic diagnosis. The grade, that is very easy. All the medulloblastoma are grade 4, that now is written in Arabic rather than Roman numbers. And then we report the molecular information. In this case, it was a PTCH1 sequence variant. In addition here, for each medulloblastoma, we analyze in parallel the tumor versus the blood, so we are able to get at the moment of the diagnosis the possibility of a germline mutation. And with this, I would like to thank you very much from the Children's Hospital of Philadelphia, and I would be happy to take any question.
That was just great, Dr. Santi. Thank you so much. You know, I stand back a little in awe sometimes with the complexity and perhaps granularity is a better word with regard to the pathologic diagnosis across multiple central nervous system malignancies. And you did just a fantastic job in making that completely understandable. We do have a couple of questions. I have one for certain. We're going to hold those, though, until the panel discussion, if that's okay.
Yes.
And if you could please stay on and join us after these next couple talks, that would be great.
Sure.
Thank you so much again. I think that was just a wonderful talk. Very excited to introduce next Dr. Yak. Hi, Dr. Yak. How's it going? It's good to see you. Thank you so much for joining us this morning. Torn had received her medical degree from Harvard and acquired a master's in community health as a Fulbright scholar from University of New South Wales in Sydney, Australia. Her residency brought her back to MGH, and clinical practice is now mostly comprised of pediatric patients and obviously survivors of childhood malignancy. Personally, it's just a pleasure to have you here, Dr. Yak. I get a chance to work with Torin on the American Board of Radiology's qualifying exam, which she chairs. And we spend a lot of time in writing questions for pediatric and adult sensory nervous system malignancies together. So thank you so much for accepting our kind invitation, Dr. Yak, and really fortunate to be here today to hear you discuss pediatric radiation oncology, brain tumors in the modern era. So welcome.
Well, thank you for the lovely invitation. That was really kind. And I am going to try to fly through a bunch of slides. So I'm going to focus on medulloblastoma because that is the topic of the morning. And these are my disclosures. And the plan for today is actually to give a little bit of an intro to radiation and protons because not everyone here is a radiation oncologist. And then talk a little bit about from whence we have come with regards to proton history, and then the late effects that we see in the pediatric population, and then the benefits of modern radiotherapy. I'm focusing most on protons, but honestly, VMAT is pretty fantastic too. And then a little bit about the learning curve with protons. So the major types of radiotherapy that you have are the X-ray based, which is the photon-based radiation, and that comes from linear accelerators or tomotherapy units, which was pioneered by Wisconsin teams. And these produce basically speed up electrons and then hit them into usually a tungsten target, which generates photons. Particle therapy or proton therapy, which is gaining more prominence now, comes from a cyclotron. We've actually tried to use other particles, including neutrons, and they're still used in the University of Seattle, but because they're not charged, they're kind of hard to control, so it's like a puff of neutrons. And then carbon ions and other heavy ions are coming, but it takes a lot more money to generate those. So this is the tomotherapy. And I just highlight it because tomotherapy is really a wonderful form, sort of what we now call volumetric arc therapy that we can do with linear accelerators, but it was Wisconsin that really pioneered this really wonderful treatment. All right, so photons and protons. So basically, most patients in the country get photons, and we have really elegant ways of delivering photons nowadays. But there's a real advantage to protons, and that is derived from the depth dose curve. So if you think of the dose deposited in tissue, which is on the y-axis, and the depth at which a tumor is being treated, you have basically a photon beam, which is usually closer to, this is a 4 mega electron volt photon beam compared to a 20. But the bottom line is they go in and then drop a lot of their energy subcutaneously, and as they traverse and exit the body, they're dropping their dose exponentially. Now with protons, the reason why they're advantageous is because this is the red line here, they go in at a relatively lower dose, and as they slow down and come to the end of the range, they drop all of their dose, and then there's no exit dose in the patient. So what happens is that you end up sparing about 2 to 3 times the amount of normal tissue patients. And that can be really helpful in the pediatric population, especially. So this is just a depiction of what protons and photons are doing. So protons are called high linear electron transfer radiation, so high LET, and that just means that they cause a lot of ionizing events, and we think it's the ionizing events in the patient that causes the DNA damage that allows us to treat tumors, and that's helpful, or disrupts the DNA. With photons, we get these beams that go in, and then you have sort of isolated lesions, whereas with protons, you have more clustered DNA damage. And that is the reason why we think protons have a little bit more oomph to them in terms of, for every ionization event, we cause a little bit more damage with protons. So when we are actually prescribing protons, we take off about 10% of the ionizing dose. So physical dose is measured in ionizing events and it's reported in gray. So when we give protons, if our aim is to give the equivalent of 1.8 gray per fraction, which is a common fractionation scheme we use, in photons, then we give actually technically 1.64 dose, and we call it a relative biologic equivalent. And so that's just sort of background. We talk in terms of like dosing proton radiation in terms of what you're used to seeing, but it actually has a factor in it that is accounted for the relative more biologic effect that protons tend to give. Now, just to remind the non-radiation oncologists, we typically give radiation and it damages, honestly, the DNA in both the normal tissues as well as the tumor cells. But we give usually small amounts every day that allow the normal tissues to repair, but the tumor tissues are really much more focused on replication. And so we end up getting a lot of DNA damage in the tumor cell by the end of treatment, but the normal tissues generally repair, although, you know, imperfect repair is some of the side effects and some of the inflammation that we cause. And then when we give radiosurgery, we do so with these very elegant techniques where we spread out the entrance dose, usually in arcs, and then get a very high dose to the tumor with really good dose fall off to the normal tissues around it. And so that's why we do the things we do. But larger fields typically have more fractionation to it, and we capitalize on the benefits of normal tissue repair. All right, so let's talk about radiation effects in children. So over 80% of pediatric cancer patients are long-term survivors, and really over 70% of brain tumor patients are long-term survivors. But radiation does inhibit growth and development in whatever tissue we irradiate. And so that's why in kids, the costs are much higher than in adults. Now, when we're treating medulloblastoma, we cause neurocognitive effects, hearing effects, and endocrine function because the brain doesn't develop as well as it would have otherwise. And then hearing and neuroendocrine, same thing, because your hypothalamus and pituitary are there. So outside of the brain, radiation has functional and cosmetic effects as well. But second malignancy is a much bigger problem in the pediatric population than it is in the adult population. And that really drives a lot of our late effects and our late mortalities. And so this is, a study that was published in Lancet by the Childhood Cancer Survivors Study. And I just want to highlight that median follow-up, this cohort is 29 years. This cohort was treated between 1971 and 1999. So it's really kind of old school radiation and chemotherapy and surgical techniques. So we've made a lot of progress since then. But just to let you know, 40-year mortality is 23.5%, and survivors at 40 years out have a 5.5 times more risk of dying than the general population. And it seems that 76% of the patients that received radiotherapy are the ones that tend to be dying earlier, with the ones that received cranial radiation or total body irradiation bearing most of the risk, as well as the patients that are getting chest irradiation. Now, what I find fascinating about the childhood cancer survivor studies is that really up until about 15 to 20 years out, recurrence of the primary tumor is actually the dominant cause of death. And then once you hit that inflection point, then we start to see a rise in the other causes of death. So pulmonary, cardiac, subsequent neoplasm, external is pretty small, but subsequent neoplasm is this yellow here, and really start seeing an uptick around 25 to 40 years. And it's really hard to get data out that long, but anyhow, it's something that we really need to think about and figure out how we can improve upon. So it's not just about death in our childhood cancer survivors, but it's also about the morbidity. So we are making progress over the years. So this is sort of the morbidity, or at least one grade 3 to 5 toxicity by decade. of diagnosis. So this is when they were treated. And basically, the 1990 to 1999 cohort's doing a little better than the 80s and the 70s. But the siblings are the sibling control in this study, and they're doing really quite well. So this is something that we still need to improve. We're curing a lot of kids, which is the good news, but it usually comes at a cost, and the costs are late. So these side effects cause frailty and aging, and this is actually really kind of cool study that I should have discovered sooner, but I didn't. That looks at biological aging after cancer treatment, and this is the Lifetime St. Jude cohort, and this is really elegant work. But the bottom line, without going into too many details, is they use 7 measures of biological age, median follow-up of 26 years, and survivors basically age faster than the regular population by about 5%. And so by the time you get out far enough, they're 5 to 16 years older. And they also, as a result, have higher risks of frailty. I took these slides out in terms of the rates of frailty, but on average, about 9% of patients, mostly more women than men, but are frail at 65 and older, whereas at this age group of 39, we have about 10% risk of frailty in our women survivors. For some reason, women do worse than the men. So this is the depth dose curve, and I'm talking about it in terms of why it's helpful to have protons for kids. And, in adults, because they're fully grown, they're not going to have the growth consequences. But in the pediatric patients, they do. But all that dose that you end up sparing. So this is the proton beam dose that by the time you treat a tumor at depth and use multiple monoenergetic proton beams, you have this general dose curve for a single beam compared to a photon beam, which looks like this. But you do end up sparing a lot of dose to normal tissue on the entrance to treating that tumor and then exit compared to photons. And that's where the biggest advantage is. And then all of that is potential growth and development for the kids. So if we can decrease that dose to normal tissue, it's really going to have a higher benefit in kids. Now, we've been doing proton therapy, honestly, since 1974, and I'll go into that in a little bit more, but that was passive scattered days. But in the last 10 years, pretty much everyone has shifted or close to shifted to pencil beam scanning. And honestly, passive scatter is really quite elegant in many ways. And I sometimes ask my physicists, can we go back to that? Occasionally it's better for some patients, but now it's pencil beam scanning, which is basically a beamlet of proton radiation that drops its dose in various layers as it paints its way through a 3-dimensional structure. And because proton beams are positively charged, we just use magnets to control where they go. And then the energy that we use is the depth of the beam in the patient. So this is just kind of fun history, I think. So proton therapy kind of started at Harvard, which is where I am right now. And the first cyclotron, Harvard cyclotron, that accelerates the protons was built in 1937. But then in 1943, it was taken away by the government. This is sort of the negotiations ongoing between Percy Bridgman, who is the chair of the department. This is Robert Wilson, who features prominently in proton therapy. And this is Heimer Friedel, who is negotiating the taking of the cyclotron away he had a cover story for use for isotopes in Army hospitals, but the reality is Percy Bridgman was onto him. He said, if you want it for what you say you want it for, you can't have it. But if you want it for what I think you want it for, of course you can have it. And so the story is that they sold protons for $1 to the government at that time. So there's a whole cyclotron. So we all know what happened with the war and sort of the devastation of the atomic bomb, but which was instrumental in ending the war. But it certainly is very controversial. And then Robert Wilson had a lot of time to think about it and created this paper and thought paper on radiologic use of fast protons. So it was 1946 when he first presented the thought of treating patients with protons. And his quote is that the medical application of protons would give me atonement for the involvement and the development of the bomb at Los Alamos. So it turns out protons aren't as newfangled as we thought. And my chair, my former chair, Herman Soot, was brought to the department in the 1970s, and he treated the first pediatric proton patient at the Harvard cyclotron. So this is what it looks like, very sort of non-assuming building, which was a fixed beam, and they had all sorts of contraptions to immobilize patients. So we treated actually over 9,000 patients before it closed in 2021. And the first patient was actually a pediatric patient that had a rhabdomyosarcoma of the back. So this is what it used to look like at the Harvard cyclotron, where we would move the patient around the beam instead of the beam around the patient. And here's, you know, a more standard treatment that we have for our pediatric patients. All they have to do is lie on the couch. We do use the anesthesia, and then the beam moves around them. So just briefly back to the side effects of treatment. Standard mortality ratios, again, in the population. We don't have many of our general population dying of benign meningiomas, but after radiation, that's actually a common tumor, and we do actually see deaths from meningioma. But second malignancies and second neoplasms are really driving a lot of our morbidity. And part of the reason is when you expose pediatric patients to radiation, they are much higher risk of developing a second malignancy compared to the adult population. So there's not that many positives to aging, but one positive is that you are less likely to get a second malignancy with exposure to radiotherapy. So it's much bigger issue in the kids. It's still an issue in the adults, but much bigger in kids. So back in 2013, actually, I was working on this for a couple of years with Christine Chung. I'm the second author on this. We did a study of all the Harvard cyclotron patients and used a matched cohort for disease with the SEER cohort. And we did a cumulative incidence of second malignancies. And this paper was rejected by 6 different journals before we had it accepted. And it was accepted under the proviso of the Red Journal, which said, well, we were not going to publish it in its current form, but we will edit what it ultimately says. And so the findings were that with the Harvard cyclotron patients, we actually found a hazard ratio of second malignancy risk in actual patient populations of 0.52. And this was statistically significant. But this was not a popular thing to say at the time because protons were, only held by a few. And so how it ended up getting published, and I'm just going to read it out loud for the conclusion, was the use of proton therapy was not associated with a significantly increased risk of second malignancy compared to photon therapy. So anyhow, this paper flew totally under the radar because probably a lot of people do what I do, is just sort of screen through your journals and read the conclusion. But the reality is this was sort of the first clinical data out there. And we had a hazard ratio of 0.52. That's actually important because I'm about to show you a study that has a hazard ratio that looks at protons versus IMRT of 0.3. And the reason for that is, and that was statistically significant. This is data coming out of Stanford, but it's actually the National Cancer Database that they were using, comparing IMRT to protons, and basically found protons decrease the risk of second malignancy, which makes sense because you're treating less volume of normal tissue. And this is both pediatrics and adult patients. All right, now I think Dr. Santi did a wonderful job of addressing this, so I'm going to fly through this pretty quickly. But You know, PD kids that get cancer, a lot of them are having these germline mutations that we didn't really know about. Now, this is another paper that was in the New England Journal, but I didn't become aware of it for a few years afterwards, and then I thought it was kind of mind-blowing. Anyhow, this was a study that looked at 565 genes, and 60 of which were autosomal dominant in over 1,100 patients that had, whole genome sequencing or exome sequencing. And then they had control patients of persons without cancer, as well as 515 persons with autism, to look at their prevalence of these genes. These were the genes that they looked for. This is just the autosomal dominant. And here's what they found, that 8.5 patients, pediatric cancer patients, had pathologic mutations in autosomal dominant cancer genes, whereas it was only 1.1% in the control non-cancer cohort and 0.6% in the autistic cohort. So when they looked at all the different types of cancer genes, up to 1 in 5 pediatric patients had some kind of predisposing gene. And that's actually a lot higher than any of us really thought about before. And then Dr. Santi mentioned this, but in medulloblastoma, it's actually pretty common to have a genetic defect as well. And again, as she was saying, sonic hedgehog and Wnt pathways are the two most common. And as I'm reading this, like, I knew about Patch and SUFU because that's driving the sonic hedgehog patients. You know about P53, it causes cancer in a lot of variety of different ways. But what was super surprising is that we're seeing these what I think of as adult cancer genes in the pediatric population that are driving brain tumors. Like, you think of APC as desmoid and colon cancer, not a pediatric brain tumor. So same thing with BRCA2. What is really interesting, though, is that I was noticing a lot of moms and kids with brain tumors early on in my career. I just had this dyad. I'm like, I wonder what's going on. And it was moms that had colon and breast cancer, and kids with brain tumors. And now I know in retrospect. So are we actually making a difference with cancer cures? Defined as 5 years, and I think the answer is yes. We are doing actually a really wonderful job. So here is the 5-year, cancer, I'd like to call it cure rate at 5 years, 83% for kids, and it's actually above 60 for adults too. So we are really doing something over the years. All this work is paying off. But are we improving the quality of survivorship? And I would argue, yes, we are. We're curing more, and we're seeing the costs of cure. That's making us more cognizant of how to improve the outcomes. And I think everything's improved. Surgical techniques are, fantastic now, imaging, everything. So it's not just radiotherapy, but, radiotherapy has really dramatically changed from the era of the childhood cancer survivor study too. And so we are much better able to spare critical structures and spare dose to normal tissues than we have been in the past. And so let's talk more about medulloblastoma. This is a tumor that you all know requires trimodality treatment, and one of those modalities is radiation, and we have to treat the whole brain and the spine. And we had a paper come out in 2016 that I had no idea was going to make the splash that it did in the UK. It basically went ho-hum here in the United States, but we ended up publishing the first prospective trial of proton radiotherapy in pediatric medulloblastoma patients. We had 7 years of follow-up. We had neurocognitive outcomes, hearing outcomes, and then also sort of talked about the lack of cardiac, pulmonary, and other late effects. And then this resulted in sort of a maelstrom of media attention in the UK, and basically requests for interviews that I was totally not prepared for. This also came out on Saturday. Apparently, Lancet Oncology knew this was going to be an issue. Came out on Saturday at 6 a.m. to try to put a lid as much on it as they could, which meant it was midnight my time when my phone started going off, and I had no idea what was going on. But I ended up on Sky TV at some like 3 in the morning. It was sort of crazy. But this happened because there was this kid that was kidnapped by his parents and taken for protons in the Czech Republic. That made a huge stink in the UK, and ultimately they weren't paying for protons at that time. And anyhow, things have changed since, but it created quite a stir. But at any rate, I put this Dali print there because I felt and I'm told I looked like I was melting. Those who actually saw me on TV and saw the clips later was really horrifying. So there's a lot of great clinical data in pediatric medulla, and in the interest of time, I'm going to start to speed up here. We can spare the hypothalamus and pituitary better than even IMRT, and that's fantastic. That's going to lead to better outcomes. So I've proven that we can improve the dosimetry to the cochlea and decrease, hearing outcomes. In medulloblastoma, we're still giving these kids a lot of cisplatinum. So there's still 16% of the kids had grade 3 or 4 hearing loss. So I think there's room for improvement, but we should also think about some of our systemic treatments as well. Neurocognition's definitely improved as well. There are many contributors, but I'm only going to talk about the radiation. And basically what we found is that in the kids treated with medulloblastoma, which is whole brain radiotherapy, so you are going to affect neurocognition in some way, shape, or form. Overall full-scale IQ drop was about 1.5 points per year. This is very related to age. So if you're less than 8 years of age, it was 2 points per year. If you're greater than 8 years of age, it was actually only 0.2. Whereas if you look at photon data, it's somewhere between 2.6 and 5.8 points per year. This is just another meta-analysis, not by my team, but by MD Anderson and sick kids, that shows that there's truly a benefit in brain tumor patients for proton radiotherapy. And this is data I want to just sort of give you. It's going to come out 10-year data on Emory cohort and then the MGH proton cohort. And basically what we found for kids treated for mostly medulloblastoma, but also ependymomas, was that for full-scale IQ, there was about a 12-point difference. And if, we're still having effects on these kids, but the normal range for full-scale IQ and its 4 components are between 90 and 110. So the only thing that we're not doing quite as well on is the processing speed. But compared to the photon cohort, we're still doing better. So endocrine function, we are also doing better with regards to endocrine function. There is an absolute dose relationship with the hypothalamic and pituitary axis. And the more you can spare it, the better. In medulloblastoma, because you give whole brain, you can't spare it that much, but the exit dose is not going to happen to the hypothalamus and pituitary. So basically, we are seeing endocrine deficits, but they tend to be pushed out more, and they tend to be in the hormones that are more sensitive, like growth hormone and thyroid hormone, and less commonly in cortisol and the sex hormones, although we do see those as well. It's also age-related. The younger you are, the higher your risk of age deficits. This is a comparison study with Emory where we showed a benefit, again, in outcomes for endocrine. And then I think I'm going to close with talking about brainstem injury. So protons are awesome. I love them, but they are, you have to use them carefully. When they've been rolled out in a big way over the last decade, we had very permissive constraints on the pediatric brain tumor populations, especially the ependymomas. And we were seeing rates of brainstem injury as high as 16%, somewhere between 2 and 16% with protons, and the highest was around 7% with photons. And so what ended up happening is that COG, Tom Merchant and I ended up rewriting the recommendations for dosimetry to the brainstem. And we don't really know why this is. We've done studies to see if it's the RBE. We just don't really know. But the bottom line is you got to be more careful with protons around your critical structures, and you can't have some of the hot spots that you can get away with IMRT and VMAT. And then I guess I'm going to just say one other thing. Patient host factors also play a role. I'm finding that brainstem injury is also more common in kids that are malnourished. And then you have these genetic predispositions. So this is a kid, thankfully, that did not have any brain injury, but he did have amazing skin toxicity with the craniospinal irradiation, and later ended up showing us to have a Fanconi gene variant. But I think I'm just going to conclude. So in short, the future is bright. Protons can truly improve neuropsych outcomes as well as endocrine and hearing. And protons are an important tool for the armamentarium. I think they complement photons. One of the slides I didn't show is actually where VMAT was better in a case of recurrent ependymoma right at the brainstem than protons, because you can get a tighter dose gradient on that. But overall, it's really an exciting time to be in radiation, and I really thank you for your attention.
I like that last slide, Dr. Yak. Thank you so much. I definitely have just a handful of questions for you, but again, we'll pause. To the other people who have joined, our participants, please don't hesitate to use the chat function. We'll make sure to address any and all of those questions for our panelists after our next talk. But thank you, Dr. Yak. That was just a fantastic discussion of radiation and medulloblastoma. So we'll move on to our next presentation. It's my absolute pleasure to introduce Dr. Rumler, who is an assistant professor at Children's Hospital in Wisconsin. Her residency led her to the University of Illinois, followed by a fellowship in pediatric neuro-oncology at Northwestern. In 2016, she was awarded the American Society of Hematology Honors Award for research surrounding pediatric malignancies. And obviously today, with her being at Children's Hospital, involves mostly seeing pediatric patients here at CHW in Wisconsin. And very excited to hear her talk today entitled Pediatric Medulloblastoma, Exploring the Role of Subgroups in Current Treatment Strategy. Sarah, thank you so much for accepting our invitation, and welcome and a virtual hello to you.
Thank you so much for that and for the invitation to talk. I'm Sarah Rumler. I'm the neuro-oncologist, pediatric neuro-oncologist here at Children's, and just wanted to discuss sort of the role of subgroups and how it's kind of changed our treatment paradigms. I am very lucky because I went last, and there are a lot of people who went before me that gave us really good talks, and you will see some of the figures that were used being repeated in my talk too, but definitely I think because they're good figures. So my goal of this talk is not necessarily to go into like extreme granular detail about these different subgroups, but really to kind of review broadly the subgroups, and then kind of use this to inform the context of how we're changing our treatment strategies for these patients. So we know, this brief introduction, we know medulloblastoma is the most common malignant pediatric brain tumor. I can go on a soapbox about how using the term malignant to describe low-grade gliomas is not appropriate, but I will not. But we know this is about 1/4 to 1/3 of all new pediatric brain tumors. They're very common. They're most common in kids who are ages 1 through 9. And by definition, these tumors arise from the posterior fossa of the brain. So discussing pathology, on the right, you can see this is just sort of a truncated version of the WHO 2021 classification for medullos. You can see it's split into sort of genetically defined versus histologically defined. However, we know, as with most neuro-oncologic diagnoses, when possible, we like to try to combine these two, the histologic and molecular features, to kind of help us come up with an integrated diagnosis. We'll see later on the talk that molecular subgroups are very important, and they are, at times the most important prognostic indicator. However, histology is still very important, and it does inform our risk stratification. So it's definitely something that we still want to know about. So classically, the medullo is divided into 4 big subgroups, major subgroups: Winch, Sonic Hedgehog, Group 3, and Group 4. We can see sort of on this chart, even with these like very broad categories, there is definitely heterogeneity in the clinical behavior of these, such as the likelihood of metastatic disease, age of presentation, et cetera, and prognosis. So we now know more about these molecular subgroups, and we know that the landscape looks a little more like this, where there are subgroups of these different groups. And again, there are at times very distinct features in some of these subgroups. So as we learn more and more, we've gained more insight, and this can also help us to develop a more well-informed strategies for treatment and risk stratification. Again, as I said, I'm not going to go into granular detail, but I did want to point out some kind of major principles or major things that we see. So on the left there, you can see the Wnt medulloblastoma. This is typically due to mutations in CTNNB1. This is about 90% of these types of patients, which results in accumulation of beta-catenin in the nucleus. These lesions have excellent survival overall. It's upwards of 90% for both of these subgroups. That being said, there are some recent data that tell us that the presence of a P53 mutation or OTX gain could have a higher risk of relapse, even in this very favorable group. Sonic hedgehog, which is the middle, the sort of pink one there, these tend to have a variation across the widest variation across the subgroups, and definitely the largest age distribution. So we typically see kind of a bimodal distribution with infants and then with older patients, so greater than 17 years. We know that infant, pediatric, and adult sonic hedgehog medulloblastoma are all very distinct diseases, and they do behave differently, and they have different molecular features as well. Many of these tumors have driver mutations, so most of them have a driver mutation. This can be in the sonic hedgehog pathway, which with genes such as SMO, PATCH, or SUFU, genomic maintenance pathways such as TP53, chromatin modulation pathways, or transcription regulation pathways such as MYC-N or MYC. These are, as Dr. Santi had said, the sonic hedgehog are the most commonly associated with germline mutations. So we can see germline mutations in TP53, like in the Li-Fraumeni syndrome, or SUFU in the Gorlin syndrome. There's a large variety of genetic variations and genetic variations and presentations of sonic hedgehog tumors, and there's also a large variation in outcomes. So an example is infants with the sonic hedgehog gamma tend to have a very good prognosis, and there's actually a very specific subgroup of these patients, which is infants with MBEN histology with SMO mutation and sonic hedgehog gamma that actually could be considered very low risk because they have absolutely excellent survival, upwards of 100%. Conversely, then you have patients who, if they have a P53 mutation, they have extremely dismal survival. So, and again, common to all of the subgroups of sonic hedgehog in particular, the presence of a TP53 mutation is very important to prognosis and often portends a significantly worse prognosis. To describe group 3 and group 4, I actually like this figure a little better because I think it kind of shows a little bit more how group 3 and group 4 are kind of the landscape of group 3 and group 4 tumors. So these group 3 and group 4s tend to be grouped together in more of the modern clinical trials for like stratification purposes. But this is because there's usually sort of overlapping molecular features, and you can have a group 3, group 4, you can have a group 3, you can have a group 4, you can have a group 4 that's more like group 3 and all these types of things. So I like that this kind of, this graphic shows the sort of Cavalli, which is our, that prior figure, that group, kind of those distinct subgroups, and then it also shows the WHO subgroups as well. But I like that it kind of, it's very illustrative, I think, of how these groups kind of overlap. The reason that these have overlapping features is probably due to how group 3 and group 4 medullo arises. So we know that group 3 and group 4 arise from the rhombic lip of the cerebellum, and then this results in kind of a genotypic and phenotypic spectrum that sort of varies according to how differentiated the tissues are of the rhombic lip. So there are some unique features for each. Group 3 comprises about a quarter of medulloblastomas, and MYC amplification is somewhat common in these groups. So about 17 to 20% of group 3s will have MYC amplification. And particularly in group 3, this is associated with a significantly poor prognosis. Group 3 is also where we are more likely to see the large cell or anaplastic histological subtype, which also portends a worse prognosis. So group 3, we know, has the worst outcomes. This is likely due to a number of factors, including the frequency of MYC amplification, the frequency of the large cell or anaplastic histology, the fact that it's more common in infants or young children, so may not be able to radiate them. And group 3 is much more likely to present metastatic disease. Group 4 is the most common of the subgroups, so it's about 35% of medulloblastomas. It's most common in pediatric as opposed to infant or adult patients. And strangely, this is also the grouping we don't know the most about. So you would think that we'd have the highest numbers with these patients, but we just, the features are not as well defined. I think, again, partially that's because there's some overlapping between group 3 and group 4. But we know, dependent on other subgroups, that prognosis really depends on not only the subgroup, but also different things like staging and extent of and age. Prognosis for group 4 is considered to be intermediate. So this is kind of a representation of our risk stratification. So historically, our risk stratification had to do with the extent of resection, the presence of metastatic disease, the histology, and the age of the patient. But I like these figures because I think they help to sort of illustrate how we are now bringing in subgrouping into our risk stratification overall. So classically, we were stratified, like we said, based on extent of resection, presence of metastatic disease, and histology. But now with our more sophisticated integrated diagnoses, it's general practice to consider the subgroups in this risk stratification, even if the patient isn't treated on a clinical trial. So the table on the left is organized, I think, mostly according to the subgroups, and kind of looking at how different molecular changes impact the risk of these patients. The figure on the right there is, I think, a little more comprehensive, and it includes those other things that we use to help risk stratify as well. So it takes into account histology, it takes into account presence of metastatic disease and extent of resection, and then kind of splits them into a low, standard, or high risk group. Some of the things that we see, you're gonna hear this a lot during the talk, but things that we tend to see that always kind of go back to leading us to that poor prognosis are presence of metastatic disease, presence of large cell or anaplastic histology, and any MYC amplification, except for one group, group 4. So group 4 MYC N amplified actually does not tend to be a worse prognosis for them. But for the most part, if we hear MYC amplification, if we hear metastatic disease, if we hear large cell or anaplastic, those all kind of point us in the direction of being a worse prognosis. So now I want to talk about treatment again. This is, is this? Okay, that was supposed to be here. So sorry, they're out of order. But again, as going back to standard practice, you can see in this flow chart that we use, unless the patient's on a clinical trial, the subgroup was not classically used to stratify patients for therapy. However, like I said, I will venture to say that most people who care for these pediatric medulloblastoma patients definitely take subgroup into account, even if they're not on a trial. Some examples of this would be potentially sparing really young patients, so even patients greater than 3, but still quite young from CSI if they have a favorable integrated diagnosis. Potentially, as Dr. Klimo had said earlier, maybe less aggressive second look surgery if there's residual tumor left, and we know that the patient has a good integrated diagnosis. And then conversely, do we need to increase our treatment? Do we need to add things like potentially intrathecals or intraventriculars if patients have a particularly high risk group and the presence of metastatic disease, for example? I want to move again now into the treatment of how we treat these tumors. So to stay within the scope of this talk, I'm just discussing newly diagnosed medullo. We know that relapsed medullo is a whole different thing, and it's very challenging to treat, and the treatment is definitely not standardized. That would be well outside of the scope of this talk. So I just wanted to kind of highlight our molecularly informed trials for newly diagnosed. There are molecularly informed trials for relapsed medulloblastoma as well, but again, sort of not able to discuss that in this time frame. So in this slide, I want to review some of the trials that have helped to either form our standards of care for medulloblastoma or to contribute to our knowledge of subgroups and how that risk stratification is appropriate based on these subgroups. So I'll just review these kind of quickly. These are all fairly well-known studies, but ACNS 0331 is a COG study. It was for patients who were ages 3 to 21 years of age. They were considered standard risk going along those, so no metastatic disease, less than 1.5 centimeter residual disease, and no large cell or anaplastic histology. So these patients were, so this compared posterior fossa radiation therapy with involved field radiation therapy. So decreasing the volume of the boost dose that goes of radiation that goes to the tumor bed. And then younger children, so kids ages 3 to 7, were then randomized to standard dose CSI, which was 23.4 gray, versus low dose CSI, which was 18 gray. What we learned about this is that the reduction of the boost volume does not compromise survival, but the reduction of the CSI dose did lead to inferior outcomes. However, not surprisingly, the neurocognitive scores were better for those patients who received less radiation. ACNS 0332 was, again, similar patient population in terms of age, but then these patients were considered high-risk patients. These patients were randomized to receive either daily carboplatin during radiation or no daily carboplatin during radiation. Everybody got weekly vincristine during radiation, but then a group of patients got daily carboplatin as well. They also were randomized to receive isotretinoin during maintenance versus none. And the results really kind of changed our a paradigm. I think this could be considered a paradigm change. The inclusion of daily carboplatin improved our event-free survival by 19%, but this was only seen exclusively for group 3 patients. The other patients, they did not get that same benefit. And then randomization to isotretinoin was actually halted because at one of the interim futility analysis, because there was really no effect on event-free survival. SJMB03, again, similar patient population, ages 3 to 21 years. This stratified patients into average versus high risk. This was also one of the earlier trials where the patients were molecularly classified. All of the patients received high-dose chemotherapy, and then this was followed by stem cell rescue on day 0 of each cycle. And then average-risk patients received 23.4 gray of CSI, and then high-risk patients received 36 to 39.6 gray of CSI. The endpoints were ERBB2 expression, and then progression-free survival, and then the frequency of mutations associated with Wnt and sonic hedgehog tumors. So what we found, the higher dose of CSI, and then there was a higher dose of cisplatin as well, did not have any effect on outcomes. ERBB2 did not, expression did not affect outcome, but this did demonstrate that methylation-based subgrouping yields a more precise molecular profile, and I think kind of helped to set the foundation for molecularly informed trials for the future. And then our early PSYOP PNET trials, so this was kind of 3 and 4, this was kind of contributed to early identification of these biomarkers that showed these prognostic relationships. So Wnt was identified as a favorable prognosis. MIC/MYC/N amplification was poor prognosis in some subgroups. The TP53 mutation was poor prognosis. And then also, again, like 0331 showed a reduction in boost volume did not negatively impact survival. So now I'll move on to some current clinical trials that use molecular features for risk stratification. These are studies that are either currently enrolling or are still open but not in close to enrollment, but still open and actively analyzing data and gathering long-term data. So if there's a paucity of outcome data, just because these studies are all fairly new, but if there was any, I included it. So not surprisingly, the majority of the trials that we're doing right now that are decreasing things like the intensity or of radiation or the number of cycles or doses of chemotherapy are mostly in our Wnt patients because we have a lot of data to tell us that Wnt has really good outcomes. Again, this is not really surprising. All of the studies in this graph apply to patients who are considered low risk Wnt patients. So they had other low-risk features, so no metastatic disease, they had good resections, and then absence of any amplifications or the high-risk histology. ACNS 1422, so these all kind of have similar things. They all had sort of a reduced CSI dose, so ACNS 1422 and PNET 5MB had the reduced dose to 18 gray from 23.4, and then reduced chemo doses and numbers of cycles. And then the SJMB12 also had a reduced CSI dose down to 15 gray, and then reduced chemo doses and numbers of cycles as well. So the data we have for most of these is very early. There is a little bit of 1422 data. It's mostly kind of looking at imaging and sort of imaging features, which we're not focused on today. SJMB12 has some prelim data. So the data is excellent. The 5-year progression-free survival is 90%, and the 5-year overall survival was 98.6%. There were 4 relapses in this group, and 1 was distant, 2 were local, and 1 was mixed. So. And then interestingly, J1403 is a pilot study that was done out of Baltimore, and this looked to completely eliminate radiation therapy. So it essentially used the 0331 chemotherapy regimen, which was the AAB regimen with all of these kind of similar chemotherapies, but it did not include any radiation after. The study had enrolled 6 patients. It actually was halted after 2 because both of those patients had very early relapses. So one relapsed after 3 months and one relapsed after 6 months. And so the study was halted. So this tells us that potentially reduction of dose in radiation does not negatively affect survival. However, radiation is still very, very important to treat Medulo. Sonic Hedgehog, SJMB12 again had some risk stratifications for Sonic Hedgehog. So these patients were given 23.4 gray CSI, which is that lower standard risk dose, and then standard chemo doses. But these patients who were skeletally mature were also given vismodegib, which is a SMO1 inhibitor for 12 months after maintenance chemotherapy. Again, the prelim outcomes are kind of as expected. So, and I think it really nicely illustrates how important that P53 mutation presence in Sonic Hedgehog is. So, you can see even your patients with otherwise good features or low risk features such as gross total resection and no presence of metastatic disease, if they had that P53 mutation, it was very significantly impacted their event-free survival. And then obviously, again, similarly, and even more so, I would say, with your patients with other high-risk features, impacted their survival as well. Peanut 5MB, again, had some differences for Sonic Hedgehog patients. This included reduction of chemotherapy that could cause secondary malignancies. So taking into account that this is the group that has the more commonly germline mutated or cancer predisposition syndromes associated with it, tried to reduce the secondary malignancies by reducing alkylator that was used. And then increasing other things that we don't think would contribute to secondary malignancies like microtubule inhibitors such as vincristine and vinblastine or methotrexate prior to radiation. Again, there's really no outcome data as of now. And then Head Start 4 literally just close to accrual like a month or so ago. This was a study that was for very young patients and then randomized them to either receive 1 or 3 cycles of high-dose chemo with auto stem cell rescue. However, the Sonic Hedgehog patients, so all Sonic Hedgehog patients except those with large cell or anaplastic histology were considered low risk. And so all of these patients only got 1 high-dose chemo cycle. They were not randomized. And then we can see the outcomes are again, actually pretty good. We think, disseminated disease is obviously much more likely to relapse, but still the overall survival is pretty promising. And then Group 3, Group 4 also has some risk stratification based on their status. So again, for Head Start 4, the Group 3, Group 4s were considered high risk. So these patients were randomized to receive either 1 or 3 cycles of high-dose chemo. They just presented some Head Start data at the COG meeting yesterday. However, that's very, very early, and I made these slides before that talk and don't want to steal their thunder, but I believe their paper is going to be out in the next year or 2. So. But don't really have a lot of outcome data for that. SJMB12, again, this had some changes for our group. They called Group 3, Group 4, put them together. So this was non-Wnt Sonic Hedgehog patients. So all of these patients had to have negative GAB1, YAP1, and beta-catenin because those are features of Sonic Hedgehog and Wnt tumors. And then they were then stratified according to their molecular features. So N1, which was like the lower risk patients, had no metastatic disease, gross total resection, no large cell or anaplastic histology, or no MYC amplifications. They got a reduced amount of CSI, and they got reduced chemotherapy cycles as well. And then our N2 patients also got, N2 was patients who had similar to the N1, except they could have large cell anaplastic histology or MYC amplifications. Those patients had lower CSI, but then they were given more frequent chemotherapy. This study also added pemetrexed and gemcitabine in for these N2 and then N3 patients, which is interesting and shows some actually really promising preclinical data and clinical data in use with both adults and kids with medulloblastoma. So it was added to that group as well. And then N3 is the highest risk. These are patients with any kind of metastatic disease, less than gross total, MYC amplifications, or MYC amplifications. So lastly, I want to conclude, I know I'm going fast, but wanted to conclude with mentioning infant medulloblastoma. Again, for those of us that treat pediatric patients, we know that infant medullo is a whole different ballgame, but there's some differences in proposed risk stratifications with molecular features, so just wanted to touch on it. Infant medulloblastoma is very unique. There are unique molecular and clinical behaviors to infant medulloblastoma. One of the big things we know is that the outcomes are significantly worse when compared to older children. One of the reasons we think is potentially the omission of CSI. And then there's also some ambiguity at which age CSI is appropriate. Almost all infant medullos are either sonic hedgehog or group 3 or group 4. And most of the time they're that sonic hedgehog subgroup, either 1 or beta or 2 or gamma. And then group 3 and group 4 is the 4 in the WHO classification. There's been a lot of strategies that have been used to replace or delay CSI and delaying until someone gets to be slightly older age. I didn't go into all of those because, again, it's sort of outside of the possibilities of this talk, but some of these include high-dose chemo with auto stem cell rescue. Some of them include systemic chemo with intraventriculars. Some of them include systemic chemo and focal radiation, but not craniospinal. Or some combinations of all of these. We know that, again, and the figure on the right, I think, illustrates nicely the subgroup propensity. So you can see on the far left there, almost all infants had sonic hedgehog tumors. And then as they got older, the group 3s and group 4s came in much more into play. Notably, I think important to look, Wnt medullo is almost unheard of. It's just doesn't really occur in very young children. And so that also could portend to the worst prognosis as well. Some things that we know, MYC amplification, again, is sort of uniformly fatal. So even in infants, regardless of whether or not they're given radiation, they still tend to be essentially fatal. And then this is a new risk stratification. This is for infants. And so as you can see from the chart, we still see patterns, right? The presence of metastatic disease, histology, those play a big role. A few things to note that are a little different than the pediatric risk stratification. There's a small subgroup of sonic hedgehog P53 wild type patients where presence of residual disease didn't seem to negatively impact their prognosis. And the presence of metastatic disease had less impact. It didn't mean it didn't impact them, but it impacted them less than other pediatric age patients. And then generally, as is our pattern, as we've said multiple times before, presence of MYC amplification, presence of P53 mutation, or large cell anaplastic, these are all really bad actors. And we know that for any age or any group, these are going to portend a worse outcome. And then finally, I just wanted to, there is one trial that is actually currently open for enrollment. It's at St. Jude, and this is newly diagnosed infant medulloblastoma. So they said infants and young children. They actually split them up into infants and young children. So infants are less than 3. And then young children up to age 5 they're evaluated using methylation classification. And then there's a very complicated risk stratification procedure, but then the kids are sort of split into these different groups. The sonic hedgehog tumor, and this is for non-Wnt, non-sonic hedgehog patients. So I'm sorry, non-Wnt patients. It can have sonic hedgehog in group 3, group 4. So the sonic hedgehog tumors are then split into 1, 2, or 3, according to the WHO classification. And then these patients are treated with systemic chemotherapy. Some of them have a lower intensity regimen than others, depending on their presence of metastatic disease and their age. And then some of them are augmented with intraventricular methotrexate as well. And then infants with group 3 or group 4 are then treated with systemic chemotherapy. We know these tend to be more aggressive tumors, so they're treated with a fairly aggressive systemic regimen up to 36 months. And then right at 36 months, then these kids are radiated with CSI. The CSI is risk-based, so there are some changes in the doses based on the risk that was determined prior to. Outcomes are obviously TBD because the study is still actively enrolling. It just opened a year or two ago. So I am very lucky because we're kind of, coming up on the discussion portion, but just a few things that I thought would be interesting to talk to the group about. What is the practice? What are people's practices using molecularly informed risk stratification for patients who are off study? What is the appropriate age to consider potentially treating a patient on an infant protocol to spare them CSI? And does the risk stratification matter? So for example, you had a patient with a really great integrated diagnosis and they were maybe 4 or 5 years old. Would you consider treating them to spare them CSI? And then how does the availability of proton therapy for CSI inform our treatment decisions? Are we more likely to treat them with CSI because we have proton, less likely, et cetera? And here are my references, and thanks everyone for your time. I will stop sharing.
Oh, Sarah, that was just great. Thank you so much. I think that was a perfect talk for us to conclude the morning session. So I loved your topics for discussion, actually. I had a question for you and Dr. Yak, and maybe you guys could tag team this. So, I think we've heard all morning, and I think all of our presenters had shared slides with regard to the granularity with which we approach, and I think we've all used the same words, granularity with which we approach this disease process now. So, from a neuro-oncologist perspective and from a radiation oncologist perspective, how are we assimilating all of this information now to make clinical decisions for our patients? Just in looking at our participants today, we have a lot of general neuro-onc and radiation oncology docs. How do we make sense of this, and how do we foresee these changes affecting our future practice?
Dr. Yak, do you want to go first?
I'm happy to go, but I think I'm also happy to defer to you. Well, okay, I'll just go. I mean, I'm using these new molecular features to change. So, for the Sonic Hedgehog P53 variant in a 16-year-old, I did bring her CSI dose to 36 based on the biology of it, where she had, it was a gross total resection, no other high-risk features except for that. And then we recently had, group 4 patient with very favorable chromosomes with residual disease, and that whole concept of whether residual matters that much. Anyhow, so I didn't put him in the high-risk category, but he's also a lot younger. And so I treated with 2340. So I'm using it even off protocol. Don't know if I should be, but I am, based on what we know so far.
That's reassuring because so are we. So
good, Sarah. So just one quick follow-up to that, Dr. Yak, especially for our clinical radiation oncologists here, and very exciting in the state of Wisconsin, both MCW and UW will be gaining proton capability within this calendar year, actually. You'd made some interesting points with regard to the decisions for utilizing VMAT or rotational therapy versus proton beam therapy. And I guess for a question for you, are you always doing comparative plans between the two? Are you always leaning towards one treatment modality versus another, depending upon any of these molecular risk factors? How do you incorporate those decisions for photons versus protons in your own practice?
Right. Well, for medulloblastoma de novo up front, we are using, I want to say exclusively protons. Right now, we actually we have 2 cyclotrons, and we brought one machine down that did our CSI, and the second one we can't actually do it. So we're using VMAT CSI, but we're actually trying to send our kids away for protons because really the sparing of the dose and the anterior structures just can't be beat. Although some patients Medicaid patients can't travel out of states, and so we do need to care for them. But so Medulo, basically, if we can, we treat them all with protons. But VMAT is remarkably good, even better than IMRT, well, similar to IMRT. And then, but for these tough cases that I'm sure you've had too, is these recurrent ependymomas that occur right next to the brainstem. I mean, the way our protons work is that we don't have as sharp a penumbra, and penumbra for the non-radiation oncologists is dose fall off. Like, we really want a nice sharp dose fall off in a brainstem that's already received 54 gray. So that's the scenario where we're using photons, and it's a really small field, so integral dose isn't as big of a deal. But you know, brainstem injury, necrosis can be fatal. So, you know, we just sort of weigh the pros and cons. But
Love that.
I'm
Wonderful.
gonna, sorry,
No,
I'm
please
gonna
go ahead.
ask a follow-up, probably more difficult questions, not straight up, but since you brought up proton photon, and this is a vulnerable population, everybody wants their kids to have the best treatment out there, and when you put proton and photon, and the data is convincing, as you are saying. So how do you counsel patients who cannot have access to proton? Are there other advocacy arm, or like working with insurance to get them where there's proton? Like, what's the overall landscape looks like?
well, you know, it's really, really tough. And we offer to send them away and ask them, you know, ask them about resources and being able to do that. And if they can't do that, they're saying, oh, you know, we'll treat you here. We have VMAT, and we'll give you the proton boost. So you do spare a lot more normal brain with the proton boost. So we do that. I haven't started yelling at Massachusetts Medicaid yet, because it's really the Medicaid program that's not allowing them to go out of state for protons. But honestly, we've been without CSI for only since February 14th. So it's actually kind of new, but if it keeps coming up a little bit more, I will. That being said, you know, the payment scheme, you know, we lose money on all of our Medicaid patients. So even if our Medicaid in Massachusetts would allow us to would pay for it, you know, the other proton centers may not take basically these patients because it's not cost effective or efficient. And so that's the other problem. Like, I don't know what center will actually take a patient for what Medicaid actually reimburses. It's super frustrating.
Great point. Sarah, going back to the original question, you know, just how you in your own clinical practice are making sense of the molecular granularity with, you know, the intensity of the systemic therapies, even with, you know, future trials, even looking at targeted or immunotherapies. Where are you at in your own clinical practice at this point in time, and incorporating the molecular data with your own clinical practice?
I think, you know, obviously it's very complicated, right? And there are a lot of things that go into it. My biggest, you know, philosophy is the best treatment is what the kid can get, right? So if they need to get treatment and they can only get, you know, a certain kind of treatment here, and they can't leave to go out of state or something like that, it's better to get them treated, you know, here than it is to not get them treated at all. So I think we definitely do take into account subgroup. I think it's sort of a medulla, I think, is challenging because, like, everyone that I can give radiation to, I want to, but everyone that I can possibly spare radiation to and have it be safely, I want to do that as well. And so I think that the complicated thing, I think, comes kind of in that, like, very young children, but not quite infant area, because I definitely think those are places where I would be much more inclined to potentially want to reduce CSI exposure if I could. But I would be hard pressed to do that if there were any kind of features that would suggest any kind of high risk, you know, category. So we definitely are using them. We've had just a run of new diagnoses here, and almost all of them have been group 3. So we haven't really had the opportunity to kind of change things. But, and obviously if there's clinical trials available as well, we offer those to families. That's kind of our standard in pediatrics, is to upfront offer a clinical trial if there's one available. So I think the things that I think about are, number one, access. What is the kid going to be able to get? If there are other, things, for example, does the kid have a leishmaniasis, and potentially could I save them radiation, or something like that. The family situation, I think, is also very important too. But I definitely think in this day and age, we would be doing a disservice to patients if we didn't consider those molecular features, because they're very important, we know. And I think that, again, even I think we were less likely to do it off study a few years ago, but now we're more likely to do it. I don't know if there are other pediatric neuro-oncologists that want to mention and want to talk as well, but that is kind of what we're doing here.
No, it's helpful. It's complicated. Dr. Santi, or actually, we have one question from the chat, it looks like, from Dr. Allison at MCW. Any further insight into why the risk of brainstem necrosis was so much higher using protons? Was this a hotspot issue or an uncertainty issue with beam arrangement, placing the distal end of the Bragg peak up against the brain stem? Dr. Yak, any other insight into that you
Yeah.
and Dr. Merchant were able to uncover?
Well, no, but we have, in terms of not myself or Dr. Merchant, but we have looked extensively into this. Harold Paganetti is one of the physicists at our institution who kind of decided on the 1.1 RBE. I don't have a slide that shows this, but when you do get your protons, I have lessons learned the hard way in pediatric cancer that I'd be happy to come back and give to the radiation oncologist. I don't want to bore everyone else, but it's a question of whether we have the right RBE for the brainstem. So we use RBE at 1.1, so 10% hotter than regular photons. But the reality is that's an average across a bunch of different cell types, and it's usually tumor cell types. We don't really know what the RBE in neural tissue is, but what I can tell you is that you can't get away with the hot spots in protons in your brainstem that you can get away with photons. And so you really do have to, focus more on homogeneity, and then also just be more careful. And frankly, some of the other characteristics of the patient, like nutrition, is really important to pay attention to. And that's something I've learned kind of over the years, as sort of a general realization. I've been doing this now for 22 years. I don't like to say it out loud that much, but you've seen a lot of, you see a lot over time, and then you start to see patterns. But we also looked at the end of range where the RBE is higher. And frankly, the way we've done it, it really hasn't been an end of range issue either. But we now have an algorithm in our pencil beam to take the highest part of the LET radiation, the linear electron, the highest RBE away from the brainstem. And now with pencil beam, there might be a slight uptick with pencil beam compared to passive scattered, which is what everyone's using now, at least in imaging changes, not necessarily in clinical. But we are now repainting the area that we're treating. So instead of just treating it all in one go, we're breaking it into like 3. It might be a dose rate issue, because when you gave passive scattered, the dose rate was a lot slower in any given voxel of tissue than the dose rate with pencil beam, which is a lot faster. So we're trying to slow it down that way. But it's fascinating. Actually, I want to comment on one other question. So what to do with the kids 3 to 5 years old? No one wants to give those kids craniospinal radiation, including me. And one of the things that we've done whenever they have one high-risk feature like anaplasia or M-positive disease is give all the chemo up front. We do the intensified chemo. So if they're like metastatic, and then we do all the chemo up front, either Head Start or, infant protocol, COG, then we give the radiation out back. And if it's a CR, I will decrease the dose. If they're a M3 or M2 patient, decrease the dose from 36 to 2340, because in that age group, that matters. And you know what? 6 months of, so it's going to take a long time to get the chemo, at least 6 months. 6 months of brain maturation in a 5-year-old makes a difference, or, you know, and in a 3-year-old, that's a, you know, a seventh of their life, or a sixth of their life. So I personally like sequencing chemotherapy first, and I have a whole different talk on sequencing of radiation in medulloblastoma. We used to give breaks during the craniospinal treatment for low blood counts. And so all of the older studies that sequence chemo first versus radiation first, they basically found that radiation first was better. But the reality is we had treatment prolongation in the patients that got the chemo first for low counts. And if you just push through the low counts and support them, you do not see those decrements in survival. So it's kind of like, for the radiation oncologists out there, it's kind of like cervical cancer and head and neck cancer, where you got to keep the treatment time compressed so you don't have the repopulation that goes on when you lose ground and introduce big breaks.
There. Dr. Krukoff, you had a question for Dr. Klimo.
Yeah, thank you guys for these great talks this morning. Dr. Klimo, you briefly mentioned posterior fossa syndrome, which is kind of this spooky phenomenon. And I'm wondering if you could just, for the audience, give a brief explanation for what it is. And then for me, I'm wondering if you have any sort of insights, inklings into kind of anatomical boundaries, or being able to predict who's going to get it, or how or where it happens. And I'm just curious to hear your experience and your thoughts.
Yeah, I mean, that's a whole that's a whole topic in and of itself. So, and it has it's obviously very, very important in medullos, because kids with medulloblastomas are at super high risk compared to other tumor types for getting posterior fossa syndrome. So posterior fossa syndrome is, I'm sure everybody has seen it, but it's this syndrome of various features, typically kind of rears its head maybe a couple of days after surgery. The hallmark feature is a difficulty in talking, to the point that they can be essentially mute. There is definitely a spectrum. You can have the most severe cases where they're non-ambulatory, mute, very emotionally labile, difficulty with feeding. I mean, it's a horrible, horrible, horrible thing. On the other end of the spectrum, they can be more mild. All kids with posterior fossa syndromes do get better, but of course, those that are more severely affected will not have nearly the degree of recovery as the ones that have a mild form of it. In terms of surgery, there are kind of known risk factors for posterior fossa syndrome, and the ones that are what I would consider modifiable. So if you have a young kid with a big fourth ventricular tumor, and it's a medullo, I mean, those are kind of non-modifiable risk factors. But the biggest thing that can impact the incidence of posterior fossa syndrome, and more importantly, the severity, is surgical technique. And that has not been really addressed adequately, at least not in my opinion, within the pediatric neurosurgical community. So we're actually making a big push. The Posterior Fossa Society is making a big push about this. I have a number of things that I do to try to mitigate posterior fossa syndrome. So I'll just kind of mention it briefly. So if you got a big fourth ventricular tumor, you just have to assume everything around that tumor within the fourth ventricle is super high risk structures. So you have all the structures in the floor of the fourth ventricle. You have the deep cerebellar nuclei, of which the dentate nucleus is probably the most important. You have the superior cerebellar peduncles, which is the outflow of the fourth ventricle, outflow of the cerebellum. All of those structures have to be meticulously preserved. And so there are a number of things that I do, such as, no retraction. I think the biggest thing is no fixed retraction within the fourth ventricle, being very careful with how you use your bipolar and your CUSA, which is the ultrasonic aspirator. I mean, there's a number of things, but that's where this whole argument of, do you leave residual tumor in the hopes of reducing the risk of this really terrible, potentially lifelong debilitating condition, posterior fossa syndrome, that's really where surgical experience technique comes into play.
Perfect, Paul. Thank you. Just a follow-up question to that. I think all of us are blessed to work at institutions where they have advanced imaging in the operating room suite. I noticed that, a lot of the data that you'd published, perhaps predated some of that technology being available for folks to utilize. Do you feel like these updated advanced imaging techniques within the surgical suite itself will have a continued impact on outcomes for patients with surgery with medulloblastoma?
That's a great question. I mean, we use the MRI very frequently, particularly with residual tumor, whether it's medullosa, ependymomas, whatnot. So I think that really does help us. Sometimes the MRI can kind of make things a little bit more complicated because it does require the neuroradiologist to be there to interpret these intraoperative scans, which are more difficult to interpret than a typical postoperative scan. You have hair, you have blood products, whatever in the field. So you really have to have a good neuroradiologist literally sitting either right next to you or on a Zoom to kind of go through these images in real time. Does it make a difference in terms of neurologic morbidity? Yes, I think so, because if you are at a point where you can't quite tell under the microscope whether it's tumor or not tumor, where the boundaries are, I think the MRI can really help much more to a degree than, say, like an intraoperative ultrasound. So we rely on that super, super heavily. I think it does help. So yeah.
Awesome. Well, we're at time for our morning session. I can't thank our morning session panelists enough for sharing their time and expertise with us. I am just immensely grateful for these wonderful talks that you guys gave. So thank you so much. We'll take a quick bio break. Dr. Day will plan to reconvene at 10:30. Is that what the game plan is?
Yes, we'll be back at 10:30. Take a
Perfect.
small break.
And for our morning
right.
panelists, please stick around for the afternoon. We've got an amazing lineup set up as well for our last 4 discussants, and looking forward to that. So we'll pause and see everybody back at 10:30.
So everyone, welcome back. And this is our next part where we're going to be switching a gear a little bit and focusing towards DIPG. And we have a little bit of change of order. Dr. Manji had some personal issues, so we were able to switch the talk. And thanks, Dr. Iskandar, for your willingness to switch the talk. And we are very excited to have Dr. Manji here. She's our next speaker, is a professor of neurology and neurosciences at Stanford University. She's also a Howard Hughes Medical Institute investigator and is a trailblazer in her field. Her research program created a novel field of CNS cancer biology that focuses at the intersection of neuroscience and brain cancer, with particular focus on mechanisms and consequences of neuroglial interaction in health, glial dysfunction, and in neurological diseases, and neuroglial interaction in malignant glioma. Together with these basic studies, her research program has advanced preclinical studies of novel therapeutics for pediatric high-grade glioma to new therapies to the clinic. And today she is going to discuss neuron glioma interactions in DIPG. Welcome, Dr. Manji.
Thank you. Thank you so much for the great introduction, and so nice to join you. So I'm a pediatric neuro-oncologist, and my laboratory, focuses on helping us understand how gliomas of childhood arise, what regulates their growth, and how we might better treat them. And one really important insight that was given to me when I was a medical student by an attending physician I was working with was the observation that if you tell a neuro-oncologist the age of the patient, they can usually tell you where the glioma is, that there is a really predictable spatiotemporal pattern to pediatric gliomagenesis. This is especially evident in high-grade gliomas and in particular in diffuse midline gliomas. And just to introduce you to some of the tumors we will consider throughout the talk, kind of as part of my journey to better understand what is really my own personal focus, both clinically and in the laboratory, which is diffuse intrinsic pontine glioma and other diffuse midline gliomas. I just want to introduce you to sort of this idea of the spatiotemporal specificity of gliomagenesis. We know that in very young children, tumors of, for example, the optic pathway tend to occur. These are low-grade gliomas that are often in association with the tumor predisposition syndrome, neurofibromatosis type 1. These can cause really substantial disability, but tend to be survivable and don't cause as much mortality as these other higher grade malignancies. Diffuse intrinsic pontine glioma, recently renamed diffuse midline glioma of the pons, in contrast, is one of the most aggressive cancers imaginable, as I think many people on the call are aware. This is a cancer that tends to happen in mid-childhood, peaking at incidence between ages 6 to 8. And it's almost universally fatal, usually within a year of diagnosis. A closely molecularly related tumor occurs in other midline structures, including the thalamus and the spinal cord. And outside of the brainstem, these other midline gliomas tend to occur in slightly older children. For example, thalamic diffuse midline glioma peaks in incidence around age 10. And then hemispheric high-grade gliomas, diffuse high-grade gliomas of childhood, occur. They can occur at any age, but they frequently occur in adolescence and young adulthood. And this spatiotemporal pattern, when we take a step back and think this really must underscore some neurodevelopmental process that has gone awry. When we take a step back and think about postnatal brain development, it's immediately clear that the spatiotemporal pattern of developmental myelination, which is this very long, relatively protracted process in the human nervous system spanning about 30 years of postnatal neurodevelopment, this happens also in specific places at specific ages. And the pattern of developmental myelination maps pretty well onto this expected spatiotemporal pattern of gliomagenesis. So for example, at a time when there is a discrete wave of ventral pontine myelination, particularly in the ventral pons and the corticospinal tracts in mid-childhood, around the time that kids have kind of a stepwise improvement in motor function, for example, being able to ride a bicycle without training wheels, being able to skip with alternating feet. This is when diffuse intrinsic pontine glioma tends to occur. And similarly, when there's a discrete wave of developmental myelination in the neocortex and its projections in adolescence, around the time that it becomes appropriate to trust an adolescent to drive a car, for example, this is when hemispheric high-grade gliomas tend to occur. And the concordance of these patterns are consistent with observations from my laboratory and from many others that DIPG, diffuse midline gliomas, and many other forms of high and low-grade glioma in fact arise from precursor cells in the oligodendroglial lineage, either bona fide OPCs or just earlier precursors that we call pre-OPCs, and certainly fits with single-cell molecular studies that have shown a really close resemblance of DIPG and other pediatric glioma cells to normal early oligodendrocyte precursors. So we may learn really important lessons about what regulates gliomagenesis by better understanding what normally regulates this process of oligodendrogliogenesis. And that raises a very basic question. What does regulate the proliferation and functional differentiation of oligodendroglial lineage cells? Well, one idea that's been in the literature for some time, first introduced in the 1990s by Ben Barres, when he was a postdoctoral fellow with Martin Raff, and then supported by some really beautiful in vitro and correlational work, is the idea that neurons themselves may regulate the extent to which their axons are myelinated, and that this could happen in an activity and experience dependent manner. This idea was really controversial for many years in the myelin field, in part because we know there are also activity-independent modes of myelin development. If you put an oligodendrocyte in a petri dish with any appropriately sized fiber, the oligodendrocyte will wrap anything of appropriate diameter, formalin fixed axons or inert nanofibers. And so many people in the myelin field felt that the activity didn't play a role. But it was controversial. And when I started my own laboratory now nearly 15 years ago, this was one of the first questions that I was really eager to ask. Does neuronal activity regulate these normal precursors from which we believe DIPG and other pediatric gliomas arise? And kind of more fundamentally, could myelin, this insulated infrastructure of our nervous system, be plastic and adaptable to experience? Could this matter for development, for learning, for memory, for other cognitive functions? And so over the years, we've demonstrated that, yes, indeed, there are times and places where myelin is very plastic and adaptable to experience, that activity of certain neurons very robustly influences oligodendrocyte precursor cell proliferation, the generation of new oligodendrocytes, and myelin internode establishment on previously unmyelinated axons or discontinuously myelinated axons. And, fascinatingly, as a bit of a side, that contributes to healthy cognitive function. It contributes to attention, learning, memory, motor function, and many other brain functions. And these interactions between healthy neurons and healthy oligodendrocyte precursor cells are mediated by importantly, by activity-regulated secreted paracrine factors, and also, fascinatingly, by bona fide synapses between neurons and oligodendrocyte precursor cells. But what happens if, instead of being a healthy oligodendrocyte precursor cell, this cell has an oncogenic mutation, like the H3K27M mutation that we believe causes the initiation of diffuse intrinsic pontine glioma? Could these really powerful interactions between neurons and oligodendroglial precursor cells be hijacked by glial malignancies like DIPG? So we wanted to understand whether neuronal activity could regulate the behavior of malignant glioma cells. And we started by looking at a pediatric cortical glioblastoma from an adolescent patient, and look at the behavior of those cells when we stimulate the activity of cortical projection neurons. We did this by taking tools from modern neuroscience like optogenetics and leveraging them to study the interactions between neurons and both healthy and malignant glial cells. So optogenetics allows for targeted control of populations of cells. In this case, we're targeting cortical projection neurons in the motor planning area. When we stimulate these cortical projection neurons optogenetically, and we can do that if we engineer the neurons to express light-sensitive cation channels called channel rhodopsin 2, isolated from algae, put into neurons. If we stimulate with blue light, which is the frequency of light at which these light-sensitive cation channels from algae respond, in this particular case, channel rhodopsin 2, then we can evoke action potentials in the neurons at the frequency at which we flash the light. So we can really control the activity of these neurons if we put an optical ferrule and fiber optic to the surface of the mouse brain. And when we stimulate cortical projection neurons in the mouse brain, in the motor planning area, we see the mouse begin to execute complex motor behavior. So we know we've successfully recruited activity in that circuit, and we can then ask really straightforward questions about how other cell types in the stimulated circuit respond to changes in neuronal activity. And when we do this in the context of a pediatric hemispheric high-grade glioma, we see that there is this robust increase in malignant cell proliferation that over time results in an overall increase in tumor burden, specifically within the stimulated circuit. We then repeated the same experiment with DIPG and found the exact same thing. And later, in collaboration with David Gutman at Washington University, we looked at low-grade gliomas using an NF1-associated optic pathway glioma model. And when we optogenetically stimulated the optic nerve prior to the age at which the mice developed these optic pathway gliomas, in this mouse model, almost all the mice, like 97% of the mice, develop optic pathway gliomas quite precisely at 9 weeks of age. If we stimulate the optic nerve from 6 weeks of age until 9 weeks of age, and then look at the optic nerves and their tumors at 16 weeks of age, what we find is that the optogenetically stimulated mice had much larger optic pathway gliomas compared to littermate controls that were identically manipulated, placement of the optical ferrule, manipulation every day, but in whom we did not turn on the light. Now, this optic pathway glioma model gives us a really exciting opportunity to ask questions not only about tumor growth, but also about tumor initiation, because we know exactly where and when these tumors are going to form. And we don't even really need optogenetics. This is a cancer that happens in the optic pathway. And so we can just modulate visual experience to change the activity in the optic nerve and then see how that influences tumor initiation and tumor growth. And so if we put mice into dark rearing conditions in this optic pathway glioma mouse model, at the time that the optic pathway gliomas tend to form at 9 weeks of age, or even just later at 12 weeks of age, and then examine the optic nerves at 16 weeks of age, what we find is that in the dark reared mice in whom dark rearing has decreased activity in that optic nerve, there are far fewer and much smaller tumors forming than in littermate controls that were simply raised with normal visual experience, normal visual stimulation of the optic nerve. And if instead we put the mice into the darkness prior to tumor initiation at 6 weeks of age, absolutely no tumors form, despite the really strong genetic predisposition to tumorigenesis in this model. And even if we replace mice back into normal visual experience conditions after what appears to be a critical susceptibility period for tumorigenesis in this model. So there's some really powerful interactions between neurons and glioma cells of various types that we really need to understand the mechanisms of. And so over the years, we've studied the way that neurons are interacting with glioma cells. And we first looked at the idea that there may be activity-regulated growth factors, activity-regulated secreted paracrine factors that can influence pediatric gliomas like DIPG and high-grade gliomas and low-grade gliomas. And what we found is that indeed there are activity-regulated factors. Different neurons regulate the release of somewhat overlapping but also distinct factors. But key ones have included the neurotrophin, brain-derived neurotrophic factor. That was kind of expected. We know that BDNF has really important influences on healthy OPCs in an activity-dependent way. Really unexpectedly, we found a shed form of a synaptic adhesion molecule called neuroligin 3. And we've also found that certain ion fluxes that are activity dependent directly influence the growth of gliomas. But focusing a little bit on neuroligin 3, this was really unexpected. So the synaptic adhesion molecule is known to play really important roles at neuron to neuron synapses. It regulates the strength of the synapses in both glutamatergic and GABAergic synapses. In a particular point mutation form, neuroligin 3 can contribute to certain autism spectrum disorders, but it wasn't known to be a mitogen in any context, and it wasn't even actually known at the time to be cleaved and secreted in an activity-dependent way. But we find that neuroligin 3 is indeed cleaved and secreted, and really robustly influences the growth of pediatric glioma cells. If you put neuroligin 3 on a cell culture of DIPG or hemispheric high-grade gliomas of either adolescence or adulthood, it very robustly stimulates their growth. So it's sufficient to cause proliferation, but is it necessary, and does it really, how much does this really contribute in the context of the much more complex in vivo microenvironment? We know there are many cell intrinsic mechanisms that are promoting glioma growth. We know that there are multiple microenvironmental mechanisms. So to test the idea, just to see how important this might be, we simply xenografted patient-derived brain cancer cells into the environment of either the neuroligin 3 knockout or neuroligin 3 wild-type brain. And what we found is really surprising. Rather than, even slowing their growth, we find that the absence of neuroligin 3 from the brain microenvironment causes an utter stagnation of growth. Here you see these GFP-labeled pediatric hemispheric high-grade glioma cells that are expanding, they're growing, they're invading across the corpus callosum, they're behaving as they do in our patients. But in the absence of neuroligin 3, we see just this stagnation of these GFP-labeled tumor cells. And we can monitor this in real time. These cells are also engineered to express firefly luciferase. And so we can use in vivo bioluminescent imaging to track the growth of these tumors. And you can appreciate here that, pediatric hemispheric high-grade gliomas or pediatric GBM just kind of stagnate in the absence of neuroligin 3 in the brain. This is also true of DIPG. There's just an utter lack of growth when DIPG is xenografted either to the brainstem or to the cortex. And this is true for adult GBM as well. But this apparent, and I should say as well, we found that the key mechanism regulating optic glioma genesis in this NF1 associated optic glioma model was also neuroligin 3 release in the optic nerve. But this apparent dependency on neuroligin 3 in the tumor microenvironment does not extend to all cancers growing in the brain. If we look at a patient-derived model of breast cancer brain metastasis, we see absolutely no effect. So what is going on? What is neuroligin 3 doing? Well, it turns out that neuroligin 3 is cleaved from the postsynaptic cell membrane of healthy cells in a strictly activity-dependent manner through the enzymatic activity of a metalloprotease called ADAM10. And interestingly, the cell type that is shedding neuroligin 3 are OPCs. So remember, I told you that OPCs actually engage as a postsynaptic partner in the healthy nervous system, and it's OPCs that are releasing neuroligin 3. The majority of neuroligin 3 in the brain is released by OPCs. Once it is released, it then binds to a cell surface protein that we've just recently identified called CSPG4, also called NG2. And this stimulates numerous downstream oncogenic signaling pathways. There's an early and upstream stimulation of focal adhesion kinase, downstream SRC, RAS, and PI3 kinase pathways. But this helps us understand, why neuroligin 3 may act as a mitogen. It helps to explain the sufficiency, but really doesn't at all explain this unexpected dependency. And so we dug deeper and looked at the gene expression changes attributable to neuroligin 3 binding in pediatric glioma cells, including DIPG. And what we found was that when neuroligin 3 binds, that there is an upregulation of a number of synapse-related genes, that the glioma cells start to express different gene sets associated very strongly with the way that we now understand they interact with neurons. But really prominently, we saw this upregulation of synapse-associated genes in the malignant cells in glioma. And this included a feed-forward effect of neuroligin 3 on its own expression, upregulation of the BDNF receptor, TrkB, as well as a number of different AMPA receptor subunits and other synapse-associated genes. And this was fascinating because it, raises the question, like there are synapses between neurons and normal OPCs, might there also be synapses between neurons and malignant glioma cells or OPC-like glioma cells? Well, when we look at primary biopsy samples, we were previously looking at expression in patient-derived cultures and xenografts. If we look at primary biopsy samples at the single cell level, we see really prominent synapse-associated gene expression in the malignant glioma cells across a range of different tumor types, including H3K27M mutant diffuse midline gliomas, DIPG, IDH wild type high-grade gliomas, IDH mutant high-grade gliomas. And we see expression again of these AMPA receptor subunits, of structural proteins associated with synaptic structures, including neuroligin 3, including PSD95. And when we look at diffuse midline gliomas like DIPG from a single cell perspective and look at the developmental hierarchy, we see that in this OPC-like cancer stem cell-like compartment of the malignant cells, that this is where the synaptic gene expression is enriched. So Does that mean that there could actually be synapses between the brain and the cancer? Well, when we look by immunoelectron microscopy, in which we can unambiguously identify the malignant cells because of immunogold labeling, we see these really clear synaptic structures. These are xenografts from patient-derived DIPG models. You can see these postsynaptic glioma cells, presynaptic neurons containing synaptic vesicles, a clear synaptic cleft, and this postsynaptic density on the DIPG cell. We see these as well in pediatric cortical glioblastoma or hemispheric high-grade gliomas. We see these as well in adult glioblastoma. And asking whether neuroligin 3 may be functioning perhaps in its most fundamental role to enable or encourage the formation of these kind of very surprising neuron to glioma synapses, we see far fewer synapses form in the absence of neuroligin 3 from the tumor microenvironment. But are these very unexpected neuron to glioma synapses just a shadow of the cell type from which we believe that these tumors emerge, or might they actually be electrophysiologically functional? So to ask that question, we performed whole cell patch clamp electrophysiology, patching onto these GFP labeled tumor cells. We did this first in DIPG. We've confirmed it in other glioma types. We put these into a very well-known, well-worked out, very experimentally tractable circuit in the hippocampus, which happens to be a place that DIPG actually frequently infiltrates to. And if we record from the tumor cells in the CA1 region of the hippocampus while stimulating the Schaefer collateral afferents into CA1, we see really clear excitatory postsynaptic currents in the glioma malignant cells. These depend upon action potentials. They're blocked by the voltage-gated sodium channel blocker tetrodotoxin. They exhibit multiple electrophysiological characteristics of bona fide synapses, including paired pulse facilitation and single vesicle events called mini EPSCs. And this first kind of synapse that we identified in DIPG and in other high-grade gliomas are mediated by calcium-permeable AMPA receptors. Now, AMPA receptors in the healthy nervous system exhibit mechanisms of synaptic plasticity. They change their strength in response to activity within that circuit. And we wondered whether the DIPG cells might be doing the same thing. When we look at the gene expression profile of DIPG, we see that BDNF signaling to its receptor tract B might be one mechanism by which the tumor cells could undergo this sort of activity-dependent adaptability or activity-dependent plasticity of synaptic strength. And indeed, if we record from a DIPG cell while perfusing BDNF over the slice, we see a much larger current in the cancer cell. And this depends upon the receptor TREC-B, encoded by NTREC2, expression in the DIPG cell. If we CRISPR delete NTREC2 from patient-derived DIPG cells prior to doing this experiment, then BDNF has no effect on the synaptic current strength. And what we determined is happening is that these cancers are hijacking classical mechanisms of postsynaptic plasticity, whereby BDNF to TREC-B signaling through CAMK2 pathway increases the trafficking of AMPA receptors to the postsynaptic membrane of the cancer cell, thereby increasing the strength of that synapse. Now, looking at the gene expression profiles, we hypothesized there may be other really important kinds of synapses and actually interactions with other kinds of neurons. So far, I've only really talked about interactions with glutamatergic neurons. Another major neuron type in the brain stem and midline structures are GABAergic interneurons. And when we look at the gene expression profile of different high-grade gliomas, we see robust expression of GABAergic, especially GABA-A receptor genes in DIPG and H3K27M mutant diffuse midline gliomas compared to other tumor types like IDH wild type or IDH mutant high-grade gliomas. And when we look at the developmental hierarchy, the single cell data from this developmental hierarchy perspective in DMGs, we see that there is a GABA-A receptor expression throughout the different compartments, but really enriched in this OPC-like compartment. So when we look by immunoelectron microscopy, this time immunogold labeling GABA-A receptors that have been engineered to express GFP in the patient-derived DIPG cells, we see really clear synaptic GABAergic synapses by immuno-EM. We can also look for these using high-resolution confocal microscopy in DIPG neuron co-cultures. So here we have patient-derived DIPG cells in blue. They're expressing these GFP-labeled GABA A receptor subunits, and we've co-cultured them with red neurons, or neurons that we've here pseudocolored or immunostained red, and they're expressing these white presynaptic markers called synapsin. And if we look in co-culture with 3D rendering, you can see very clear co-localization of pre and post-synaptic puncta on the neurons and glioma cells. These GABAergic synapses in DMG are electrophysiologically functional. We see very clear GABA A currents, GABA A mediated currents that are sensitive to GABA A receptor blockers, picrotoxin and bicuculline in DMG. And importantly, these are in the cancer cells, these are actually excitatory synapses rather than them being hyperpolarizing and inhibitory, as we see in normal neurons in the cancer cells, and actually also in normal neural precursor cells, including OPCs. GABAergic signaling is instead depolarizing and excitatory. And importantly, positive allosteric modulators of the GABA A receptor, like benzodiazepines, and I'm showing you here data from lorazepam, strongly augment these GABAergic currents in DMG. So that would suggest that actually benzodiazepines might be growth promoting in DMG. And somewhat alarmingly, when we look at patient-derived xenograft models of DIPG, we see a dose-dependent increase in glioma proliferation when the animals are administered lorazepam at relevant doses. This accelerates tumor growth and shortens mouse survival. So just as we need to understand the mechanisms that we could disrupt to slow DMG and other pediatric glioma growth, we really need to understand which medicines we're using that may be inadvertently harmful. So all of this suggests that GABAergic neurons may similarly promote the proliferation and growth of DMG. And indeed, if we optogenetically stimulate GABAergic interneurons in the tumor microenvironment in vivo, this increases DMG growth rate. So I've told you now that both glutamatergic and GABAergic neurons promote DMG proliferation and growth. It turns out they also influence DMG invasion. And we've started to look at other neuron types, particularly brainstem neuromodulatory neurons like cholinergic, serotonergic, and noradrenergic neurons, and all of them very robustly promote the growth of DMG. This suggests that there may be some convergent mechanism by which all these different neuronal types are influencing glioma growth. And one potential convergent mechanism, I know I'm going up to my time, but I just have a couple minutes left. I promise to finish very close to time. One potential convergent mechanism is the induced membrane depolarization itself, which makes some sense when we think about the fact that depolarizing waves of that synchronized waves of depolarization propagate through normal neural stem cell niches, normal precursor niches during brain development in ways that seem to be very important in regulating normal precursor cell proliferation and differentiation. And the tumor cells are undergoing membrane depolarization through each of these different mechanisms, and that's a very metabolically expensive thing to do. So it may be advantageous to the cancer. There may in fact be depolarization regulated growth or voltage regulated signaling that is influencing the cancer progression. And so we can test this idea that it's really the membrane depolarization at the end of the day that's so important, again using optogenetics, but this time expressing these light-sensitive ion channels in the cancer cells rather than in the neurons. And if we do that, we can use blue light to depolarize the glioma cell. If we do this in vivo, this was actually done with DIPG cells that we put in the cortex so that we could depolarize them with light delivered at the surface of the brain. We see a very clear increase in DIPG cell proliferation from the membrane depolarization itself. Now, the tumor cells aren't just undergoing membrane depolarization, they're very actively regulating the strength, the size of that depolarizing current. So we can use optogenetics flashing either a short pulse of light or a longer pulse of light to keep these cation channels open for different lengths of time and induce either a medium-sized depolarization or a much larger depolarization. And when we do that, we see that there is a depolarization magnitude dependent effect on tumor cell proliferation. We can visualize this electrical activity in the glioma cells using genetically encoded calcium indicators. And I think that this particular calcium imaging movie of DIPG cells in the brain really underscores what for me has been a very startling new understanding that this cancer is an electrically active tissue. And that's not how we have been approaching either understanding or treating it. So we now need to understand the mechanisms of malignant circuit assembly, plasticity, and evolution over the disease course to determine the granular details of those voltage sensitive mechanisms of proliferation, which will give us insights for therapy as well as insights towards normal neural development and plasticity viewed through this magnifying glass of glial cancers. In summary, DIPG and other pediatric high-grade gliomas integrate into the neural circuits that they invade. They do this through bona fide neuron to glioma synapses that are then elaborated and reinforced through mechanisms of adaptive plasticity, as well as through purely electrical mechanisms through these activity-dependent ion fluxes. This is important not only in mouse models, but in patients as well. I'm showing you here data that was generated together with Sean Hervey-Jumper in adult glioblastoma, but it shows that the degree to which the tumor is integrated into the rest of the brain, the degree of connectivity strongly predicts survival. So as we understand this, we may be able to develop new neuroscience-inspired therapies to help improve outcomes for DIPG and other pediatric gliomas. And I'm excited to say that some clinical trials have gotten underway. Any way we disrupt this in experimental models slows these cancers. I'm really running out of time, so I'm going to skip the last point and just come to the idea that there are clear mechanistic parallels between these normal neuron glial and malignant neuron glioma interactions that really underscores the extent to which these cancers are hijacking mechanisms of normal neural development and plasticity and demands that we approach these tumors from a neuroscience perspective. I'm going to skip to the end, make sure I highlight the people who did the work, Hamsa Venkatesh, Ewan Pan, Katie Taylor, Tara Barron, Richard Drexler, and Avishai Gavish. Thank our collaborators, funding sources, and of course the patients and families whose donation of tumor tissue enables all that we do. Thanks for your time. Sorry for going a few minutes over.
Oh, that was a fascinating talk, Dr. Monti. And since you can't stay for the panel discussion, we can take a few questions that's specifically for you. And I will start. I mean, this whole field is so fascinating. Since DIPG is growing in a developing brain, do you think these synapses between the neurons and glioma is coming at the expense of a normal synapse that it would develop, or is it an additive thing?
This is a great question. It comes to a whole sort of the other side of the biology is that just as neurons are influencing the glioma cells are very robustly influencing neurons, and they're causing not just neuronal hyperexcitability, but also real functional remodeling of neural circuits that includes aberrant synaptogenesis and actually aberrant axonogenesis. So there's a structural remodeling of neural circuits. This is probably a big contributor to the symptoms that patients experience. So there's very much an effect of the cancer on the nervous system, both in its development, but also remodeling existing developed circuits.
And do you think that might be what makes surgically resecting these a lot more difficult because of these aberrant? Because normally when we surgically resect, we know what the normal boundaries are, how fibers are splayed and where we go in. Do you think this is all kind of
I should have shown a sort of zoomed out picture of what these diffuse midline gliomas look like, and also diffuse hemispheric, all the diffuse gliomas. They're diffuse because they're infiltrating neural circuits and forming synaptic connections and then moving on. Their daughter cells move on to make new connections. They are integrating into the circuit. There's no way to surgically resect them. It's like pepper sprinkled throughout the brain. And so we need to think about other ways to disintegrate these integrated cancers. And so maybe I'll use this as an excuse to show one slide. Because of this recognition, I started looking for immunotherapy approaches, because I realized that, not only do these connections promote growth and invasion, they also protect the cancer cell from our traditional therapy. So we're going to need some kind of special forces cell to go in and like pluck them out one by one. And, this is the topic of another talk, and I'm not going to get too much into it, but this immunotherapeutic approach in DIPG has been very promising. There's one kiddo who's had a complete response that's been durable for almost 4 years, but usually we see helpful, but incomplete responses that are insufficiently durable. One thing that has been amazing about this and really underscores how these are tumors that cause neural circuit dysfunction but not destruction is within weeks of a good therapeutic response to the CAR T-cell therapy, we see major neurological improvements. I mean, literally wheelchair bound to walking kind of improvements. They just don't last in most patients long enough. We're working on that. And part of how I think we have to work on that is understanding the neuroscience of that immunotherapeutic approach. There's just extensive crosstalk between the cancer cell, immune cells, and neurons. And we think that's one of the major things that's limiting immunotherapeutic efficacy in this disease.
Dr. Manji, great talk. I heard you talk at SNO too, and every time it's really thought-provoking, and it has so many implications in terms of what we do on the surgical side, and it's just it's this whole field and what you guys are getting into really feels like you're starting to put together these sort of disparate observations that a lot of us have made kind of on our own, and starting to make sense of it. So just thank you for what you do.
Thank you.
I know there's some interest in like gabapentin and trying to take advantage of some of those known interactions.
Absolutely.
Do you have thoughts on that? Or
I do. So, Sean Hervey Jumper led a study that I was lucky to be involved in which he found that one of the key synaptogenic factors released by glioma cells that influence this neural circuit remodeling and promotes growth is thrombospondin 1. And gabapentin blocks the thrombospondin 1 receptor. We have found that in DIPG, Neurontin, gabapentin and pregabalin are similarly therapeutic. And actually, this is totally new data that we haven't published yet, but I'm going to share it semi-confidentially here, not that confidentially. When we look at patients who have done better or worse on the CAR T-cell clinical trial, those who were on gabapentin did markedly better. So we've tested that now. It seems to augment our ability to treat the tumors with immunotherapy, and we've now added it onto the clinical trial for everybody.
That's fascinating. Do you think that's specific to CAR T-cell, or like I'm tempted to just start putting all my glioma patients on gabapentin, because I mean they're on anti-epileptics anyways. We could use anti-epileptic dose. There's not that much.
Yeah, there's not much of a downside. I think it's so there are some medicines to stay away from in a disease specific way, like benzodiazepines and DMG. And then there's some medicines that we use all the time that are very, very safe and that might be extraordinarily helpful. And I give gabapentin as soon as I possibly can to everybody. So, if I have any excuse, I give, having trouble sleeping, let me give you a nighttime dose of gabapentin. Are you having any pain? I'm going to give you gabapentin. I really think we need to study it in a prospective way, but it's one of those medicines that I think is broadly helpful in pediatric gliomas. Other ones, include certain anti-seizure, not any anti-seizure medicine, but we've tested perampanel to block the glutamatergic, the AMPA-dependent synapses, and that's therapeutic in preclinical models. If I need an anti-seizure medicine, I try to use that one. We've also found levetiracetam specifically in DMGs, not in other high-grade gliomas. That one is specific for DMGs because it modulates, interestingly, it modulates those GABAergic synapses in the DMG. And actually, retrospective clinical data shows that kids with DMG who were on levetiracetam did better than those who weren't. And we have a preprint on that if you're interested. So there's a few medicines I tried to use, and I think we need to, as a community, really study the best we can in a prospective way. But when I have nothing to reach for, which is often the case in pediatric gliomas, if it's a DMG, I will almost certainly give levetiracetam, add perampanel if it's tolerated, consider, Neurontin if there's any indication. So I think there's the broad opportunity to repurpose the right medicines in the right disease context. But the benzodiazepine story is a good cautionary tale about why we really need to understand the neuroscience of each individual molecularly defined tumor, and not just reach for anything. Reach for the things that there's preclinical evidence, or at least preclinical evidence, are helpful. Better if there's retrospective patient, real world patient data to show that it's helpful. But yes, I think there are tools in our toolkit we're not using enough. That was a longer answer maybe to your question.
That was great. I mean, I have like 4 follow-ups and I'm just restraining myself from asking. But the first one is, do you have any early sense on like dose? Like, can it be a low dose, can it be a high dose?
We haven't studied dose. We've been using standard dosing.
Standard dose. Pain or anti-epileptic dosing?
Pain dosing.
Pain dosing, okay.
But I don't know what's best. I mean, that's what we've been doing. We've been sort of going up as tolerated.
Cool. Thank you.
Great. Well, we'll continue to work on how we can repurpose medicines we already have that are designed to get into the nervous system. And maybe the next time I visit you virtually, I can share more.
It was just a wonderful talk, Dr. Manji. Thank you so much for your time. We appreciate you. We know West Coast time is obviously very different than Central Standard here, so we appreciate you with the earlier morning out there in order to share your wisdom with us. So thanks again.
Thank you so much for having me.
You bet. You bet. All right.
Should we move on to our next?
We should, Dr. Krukoff. That'd be great. Thank you.
So it's a real pleasure to introduce our next presenter, Dr. Peter Madsen. Dr. Madsen and I have known each other since we were medical students, which seems like yesterday, but turns out it's not yesterday anymore. Dr. Madsen is an assistant professor of neurosurgery and oncology at the University of Pennsylvania. He's the director of the Neurosurgical Oncology and Translational Research program for the Division of Neurosurgery at Children's Hospital of Philadelphia, CHOP. Through various grants and collaborative partnerships with CHOP neuro-oncologists, Dr. Madsen directs laboratory efforts testing CAR T-cell therapies for multiple types of pediatric brain tumors with the hope of translating these approaches into clinical trials. He did his medical and neurosurgical training at Penn, and he did his fellowship at CHOP. So, Peter, take it away.
Great. Thanks, Matt. Can you guys hear me okay? All good? Awesome.
All good.
Awesome. So thank you so much. This conference has been fantastic. It's really wonderful to be a part of it. It's a tough act to follow, Dr. Manji, but I will do my best. And so I'm going to be talking today about translational research, a little shift from some of the early clinical stuff, but really focus on topics where I think surgeons can play a large role, sort of bringing the laboratory into the operating room. And that's one, generation of new model systems, in particular organoid model systems, but then using those model systems to pilot and study sort of the next phase of care. And for us, we have a lot of interest in immunotherapy. So jumping a little bit off of what Dr. Manji was talking about at the end there, the GD2 CAR T-cell therapy, and maybe some iterative advances in that work. So we'll start off with the organoid program, talk about why modeling is so important for pediatric brain tumor research, and then some of the successes that we've had in overcoming those challenges by looking to organoids. Specifically, this is the DMG session, so we'll spend a little bit of time talking about how we've generated some modules in DMG. and then move on to the use cases in preclinical testing. So even though there's been a ton of progress in terms of modeling pediatric brain tumors, there's still a challenge. We've heard multiple times today now about the molecular age of pediatric brain tumor research. And with each few months or so, it seems like we're discovering new subtypes and subtypes of these tumors. So coming up with models to study each of those is quite a challenge with such a diverse histology. A lot of the tumors that we work on and we care about are low-grade tumors, so low-grade gliomas. And historically, these have been a challenge. They're very slow-growing tumors. Generating cell lines is tricky and often requires some work to manipulate those cells in ways that maybe might lose the true nature of how they behave inside the body. For diffuse midline glioma, historically, this was a tumor that was rarely, if ever, biopsied. Now that's definitely changing. But access to tissue has always been a challenge in this disease, especially with biopsies being performed now. Most of that tissue will go on for clinical purposes, and not much is left for research purposes. So this may be a way to address that. Then the tumor microenvironment. We know that there are, as we just heard, some really important factors that influence tumor growth and respond to treatments beyond the tumor cells themselves. So our traditional cell cultures do not recapitulate those aspects of the tumor. You lose that whenever you're dealing with a clonal selection of tumor. So tumor organoids may be a way to address that as well. So yeah, just thinking about the cell lines, xenografts that we traditionally use, they're a clonal cell population, very homogeneous. They may have altered gene expression, different phenotypes by sort of living in plastic that may not capture what the disease state was inside the body. And often they're very hard to make and time consuming. So these are some of the issues that we've tried to overcome with our approach in the lab. So how did it get started? So we were fortunate enough to partner with a group at Penn, Hong-Joon Song, who his main focus is really in sort of normal brain organoids, so generating little brains in a dish, but got into tumor organoid development through collaborations at Penn and generated a large wealth of GBM organoids. And really, the major advances there were the techniques, the laboratory techniques to enable that and to grow those in culture. So we adopted a lot of those techniques and brought them over to CHOP and have now applied them across a really diverse range of brain tumor histologies. So let's go through the program. And I think first it's important to highlight the team doing the work. So Dr. Mateus Koptaira is sort of one of our lab directors and really is spearheading much of this work day to day. And we have some people in the lab who are just fantastic on the technical side of getting these done and characterizing the organoids. Then, of course, it's a huge collaboration with pathology. All of our tissue goes to them first. So you heard from Dr. Santi today and Dr. Van. They are amazing and extremely collaborative in this, and it takes that kind of team effort to get something like this done. So what is the workflow? So we do surgery, and our surgical techniques have changed some to enable this work. It's really important in my mind to try to remove the tumors in a piecemeal fashion, try to get as large a piece as possible to enable these organoid development. And try not go straight to the CUSA early on, really to get large specimens, because what needs to happen next after it goes to pathology, we quickly get it to the lab. And then there's a processing that occurs. There's an important aspect of slicing these tumors into the right size, getting them down to about 1 to 2 millimeter size fragments. And then the next phase it was critical, and this is where we adapt a lot of techniques from Hong-Joon Song, and there's a physical aspect of how you grow these. There's a certain way of shaking and rotating these that allows for rounding and proliferation of the organoids so that they can be passaged and studied. So this is something we try to do on almost every case, anytime we have sufficient tissue to enable it. So how are we doing? So over the past about 2 years or so, we've been able to generate over 100 organoid models and bank those. We have well over 80, close to 90 now of models that are in sort of the shareable phase where people can request them. We have them banked. You can get them in your lab. Some still in a provisional status we're working on, and then some we don't have enough to really share. But the big thing here to highlight is just really the success rate. We are over 90% successful in generating organoids from a huge range of pathologies here. It's that kind of success rate is just not seen when you're trying to generate cell lines in other fashions. So that's something to really highlight here, just the sort of universal success that we can get to generate these models. So let's go into a little detail on some of the more challenging ones. So low-grade glioma, like I said, it's sort of a hard thing to model in a dish because of just how slow growing it is. You have to manipulate it, sometimes insert oncogenes or give specific growth factors to get it to grow. But with us in the organoid approach, we have 94% overall success rate across a broad sort of different histologies of low-grade gliomas. Here's what they look like. So right out on day 0, you see these cut fragments. And then over time, they expand and they start to round. And that's the sort of the proliferative capacity of them. And like I said before, the nice thing about using organoids is that you're capturing the tumor microenvironment along with the neoplastic component of the tumor. So here we've stained for microglia within our organoids, and you can see staining in green the IVA1 positive microglia that are present at time of resection and initial processing of those organoids on day 0. But even out to week 4, that organoid in culture retains those microglia. And then over here, we've the organoids can only get to a certain size before they're unable to receive nutrients from the media. They start to necrose centrally, so we have to cut them and passage them. So a couple weeks in, we'll start to do that once they've rounded well enough. And even after passage, you still see elements of that tumor microenvironment there. Now, clearly, it's decreasing over time because the cells that are proliferating are the neoplastic cells. And you're losing out on any of those infiltrating, say, T cells or the microglia or other components that may not be, that are not, they don't have the proliferative capacity. The other important thing to look at too is just those drivers of proliferation. So in this low-grade glioma, we looked for evidence of MAP kinase pathway activation, and you can see that at time of resection, you have high phospho ERK levels, and those maintain with time as well too, showing dependence upon that MAP kinase pathway. And then looking just molecularly too to see if those drivers are still present within our organoids. So we did qPCR looking for the key BRAF fusion in the sample and others, and we see that it's maintained over time. Okay, what about another challenging model system, another challenging tumor to model, craniopharyngioma? So another benign, very slow growing tumor, hard to get in the dish, hard to grow in cell culture. You have to do lots of different things to try to get it to grow. But with the organoids, we've been very successful. Almost every case we do, we're able to get these organoids to develop. And I think the cool thing here is it's sort of a nice recapitulation of the disease that we see. So there's a sort of a central solid component with this prevalent cyst that forms around it. And that's some of the major problems when trying to deal with craniopharyngioma are that cystic component. That's what's compressing the optic nerve, or that's what's compressing the hypothalamus, causing dysfunction or problems. And so now that we have a model system in the lab where we can maybe manipulate in certain ways, and this is what we're doing, try to see, can we affect cyst formation? Maybe you're unable to get a complete resection, but you want to prevent a cyst from recurring or something. Or this is a nice model system to do that you could not do in traditional cell culture models. This is just to point out that, we've tried this on every case that comes across us. So I had a run of a couple hematologic malignancies a few months ago where we went through the same pipeline of submitting them for organoid generation. And our oncologists were very grateful for that because we were able to get a growing model system for them within about a week. And these were 2 erythroid sarcomas that one had a novel fusion, sort of blew through multiple types of treatments and relapsed. And actually, it sort of highlights the role that these organoids may play for us currently now and certainly in the future in terms of developing precision therapies for our patients. So we were able to test out drugs on these organoids, but then also we're pushing a little bit further and actually designing antisense oligonucleotides against one of this patient's fusions to see if that may be effective now that we've exhausted a lot of our chemotherapeutic options. So just a glimpse into the future of how these may play a role in clinical care. All right, what about for DMG? Like we said before, there are great models out there, but they're somewhat limited, and a lot of them are from patients who have had treatment, have seen radiation, or maybe even autopsy specimens. So trying to get more models that represent the initial disease state, I think, is going to be very important. Like we said, the problem here is often that we don't get a lot of tissue to work with on the research side. So there are groups have done some great work, especially David Daniels out at Mayo, of demonstrating that when we do needle biopsies, we can actually obtain small fragments of tissue from washing the needle in between biopsies. And from those, they were able to generate cell lines. The only problem there is it takes quite a lot of time and a lot of effort. So 6 to 8 months to generate those cell lines. Well, we thought we'd try this in our organoid system, and similar protocol, needle biopsy, needle washings between the core specimens that are removed are washed out, put into a dish. There are fragments that we can, we don't get this many fragments, but small fragments that we can cut and go through that organoid development pipeline. And so here's what we get. We do get organoids that form from these primary patient samples at their biopsy. And from there, too, we can process them further, get single cell suspensions, and generate cell line cultures as well from them. So I think this is a really valuable tool for the DMG community, and we'll hope to use this more for all of our patients. So like I said at CHOP, we're doing this on every case that comes to us. But it would be nice to be able to deploy this for more patients at more centers. So we've looked into ways of adjusting the pipeline so that we can be more inclusive of specimens. So for us right now, we're running these through our pipeline very quickly. Within about 60 minutes, they're already in the lab being processed. But what about specimens that have been stored, either in media or stored in liquid nitrogen? So here we've explored generating organoids from tissue preserved in media. So comparing a primary specimen that was taken fresh and processed, we generate organoids very easily from that. What about a tissue that's been in media for up to 72 hours? We could still generate viable growing organoids from that tissue that's just been sitting usually at 4 degrees in a pathology lab or something. We can still generate organoids from those. What about from frozen specimens? Again, the comparison, the fresh tumor specimen, we're able to grow down our standard pathway. And then from freezing specimens, we can even recover organoids from that and grow organoids from frozen tissue. So this has the potential to expand this to more of our patients, say, late night cases or things on the weekend, whatever. We have more flexibility, but we're hoping that this can expand to patients at other sites, other centers, as this moves forward as a precision medicine tool. All right, so a little bit on the research, back to the research side. How can we use these organoids in preclinical testing? So talk a little bit and transition a little bit to thinking about immunotherapy. And this work I do in collaboration, very close collaboration with Dr. Jessica Foster, who's an amazing neuro-oncologist here at CHOP. She's had a lot of these insights and hypotheses, and just want to share some of our work with you. Dr. Manji brought up her incredible work, work that's really giving hope to a community that desperately needs it. So this is the GD2 CAR T cell therapy that has now been beautifully published. The benefit here, of course, GD2, it's highly prevalent on DMG cells, but not on normal brain tissue. We can use that to our advantage and use it as a target. But looking back at some of the preclinical work, there were some concerns about that this as a target, because in some of the thalamic model systems of DMG, there was toxicity, significant toxicity when you go after the thalamic form of DMG using the GD2 CAR T cells, almost universally fatal in the mice due to swelling, herniation, hydrocephalus, and death. So our group, Dr. Foster, had the thought that maybe we can try something that's a little less toxic, use mRNA to drive our CAR T cell therapy, to open up the door to patients who have tumors in those locations who would not maybe necessarily qualify for clinical trials, and give them an opportunity to still have a GD2-directed CAR T cell therapy. So the idea, instead of using a viral CAR T cell, which is sort of an always-on, always active, persistent product, using mRNA instead has both some advantages and disadvantages. So that advantage is maybe we can mitigate toxicity by using something that degrades over the course of a week or two. So mRNA doesn't stick around forever like a viral vector would, a virally driven CAR T cell would. So utilizing mRNA for a transient product that can limit our toxicity. But the downside there, right, is that it is transient. So dosing becomes important. But so you're turning a cellular product from something that's always active, always on, to thinking of it more of a pharmaceutical, more like a drug that has a half-life. So the way we do that, we generate mRNA in vitro, electroporate our T cells, and we generate our CAR T cells that way. So a lot of in vitro testing done on this, but I just want to sort of highlight what we did using the organoids. So you can see our organoid down here. The T cells are all TD2 red here, TD2 tomato red. They attack that organoid and slowly break it up. Here's some more evidence of that. We turn our organoid into just single cells and run through flow cytometry. You see significant killing of the tumor over time. And then just on immunofluorescence too, you can get a better sort of visual representation of what's happening. So a large influx of GD2 CAR T cells into that organoid there. The red represents the cleaved caspase 3, sign of apoptosis and cell death. And then just visually here, you can see just disintegration of that nice clean organoid from the control to the experimental, just sort of disintegrating apart. So we've moved this into in vivo work too, and using a very aggressive model for DMG. We just gave one dose of our mRNA CAR T cells, and we saw what we expected to see, that it was not effective because it has a transient effect. It's only around for so long. So we had to come up with a way of delivering CAR T cells multiple times into the CNS. So a lot of work done on an implantable cannula system that the mice can keep for a long period of time that we can treat through. And when we do that, we change our model system to something a little bit less aggressive. We try to recapitulate some of that toxicity data and gave very high doses of the mRNA CAR T cell, GD2 CAR T cell, and saw control of that tumor, but it was toxic. So and the mice were dying in a similar fashion. So we decreased the dose, sort of highlighting the advantage here of using the mRNA. Decreased the dose, got tumor control, and that the cytotoxicity effect has gone away here. Now, again, this is a slow-growing tumor model. You have to take this way out to start seeing the effects there in separation. But this is just what we use to sort of highlight the benefit of toxicity there, less toxicity. Another area of interest in my lab is ATRT, another devastating tumor that affects really young children. And this is another use for mRNA CAR T cells that we've been pursuing. In this case, it's more that mRNA is just so easy to work with that we can adapt existing technologies, existing CAR T cells, use an mRNA version of it, and test it very quickly in our lab. So just a little about Claudin-6. This is a tight junction protein. It's an oncofetal that's expressed in multiple different cancer types. Is actually being targeted in phase 2 clinical trials by the German biotech company BioNTech. And what we've known for a while now is that Claudin-6 is actually highly expressed in ATRT. So we saw that as an opportunity to bring that to patients who are in really desperate need of new therapies. So again, utilizing mRNA, we were able to make our CAR using mRNA technologies, get it into the T cells, and then we have a working product ready to go very quickly. And we did all the in vitro work as well, but this is just the in vivo studies showing really efficacious cytotoxicity and decrease in tumor burden over time. Again, with serial dosing, we have to give this multiple times because it is a transient CAR T cell product, and really great survival advantage in the Claudin-6 treated mice. Here's just what some of it looked like. This is a big tumor in the control animals, and then when we dose multiple times with our Claudin-6 CAR, we see eradication of that tumor, and it's supported by the bioluminescent imaging as well. The sort of interesting thing about that project, where things are moving with that, is the BioNTech. Their product right now is a mRNA vaccine boosted CAR T cell product. So they deliver the CAR T cell and boost with an mRNA that encodes the antigen. So you can increase in vivo inside the patient the levels of CAR T cells without having to redose. So we're pushing that forward in a brain tumor model to see if we can enhance persistence of the CAR T cell throughout the body and throughout the CNS as well. So more to come on that. All right, so where are things headed? So in the organoid program, like I've said, there's a role here for applying this to all of our patients and enabling a truly precision medicine platform, generating what we'd like to think of as sort of patient avatars that we can do whatever testing we need on it to see what may work for them. We're pairing this with other work going on in rapid intraoperative diagnostics using nanopore technology, rapid sequencing. So sort of a combined precision medicine program there. And then on the mRNA CAR T cell side, we have work ongoing right now to optimize our delivery strategies and how we're going to best implement this in patients, and then hopefully get it to clinical trial. So just a quick plug for the Children's Brain Tumor Network, that all of that organoid work sort of falls under and is available for anyone who is doing research out there, who has interest in this. We have specimens, we have the model systems, we have paired clinical data for tons and tons of patients, and it's just a great resource for anyone out there who needs it. So with that, thank you very much. Again, this was an awesome conference to be a part of, and I really appreciate the invitation to be here. So thank you so much.
Thank you, Dr. Madison. That was, again, a great talk. I think we'll keep the questions for the panel discussion when you're ready. Dr. Morris, you want to go ahead?
Yeah. So we'll move on to our next speaker. It's my pleasure to introduce Dr. Christopher Tinkle. Dr. Tinkle is an associate member in the Department of Radiation Oncology at St. Jude Children's Research Hospital. He completed his undergraduate studies at the University of Texas and received his combined MD-PhD training through the Tri-Institutional Training Program at Cornell and Rockefeller University under the mentorship of Dr. Elaine Fuchs. He then completed residency at UCSF before settling in the Midwest and joining St. Jude Children's Hospital with a clinical focus on pediatric brain tumors. And he also runs a research lab investigating ways to combine radiotherapy with selective inhibition of DNA damage repair to improve the therapeutic response. We're excited to hear his talk today entitled The Role of Radiotherapy in the Management of DIPG.
Okay. Can you hear me okay?
Yes, we can.
Okay, great. Well, it's a real pleasure and an honor to be a part of this fantastic symposium. I will bring these wonderful basic and translational talks back to the clinic to maybe a humdrum discussion, but a topic that really occupies most of my time at work, and certainly a lot of my time outside of work. It's a topic and a disease site near and dear to me. So I just want to review the role of radiation therapy in the management of DIPG. There's a lot of data-dense slides. This is maybe more for trainee purposes or just to have some of these references. So we'll see how far we get. So next slide. So I just wanted to put in context the disease entity that I'd like to focus on today with regards to radiation therapy. So there's a lot of different verbiage in the literature, and I think oftentimes can confuse the topic. We've got brainstem glioma, DIPG, and now DMG. And really, what does that mean from a local control perspective? So historically, brainstem glioma have been defined based on local intervention, right? Neurosurgical and radiotherapeutic management. And these have been broadly defined as non-diffuse brainstems or diffuse brainstem tumors. And whereas the non-diffuse tumors typically are managed with surgery plus or minus systemic therapy, now with targeted therapy, and to a much lesser extent, radiation therapy. And it's the diffuse brainstem tumors that I'll focus on. So next And these have been coined clinically as diffuse intrinsic pontine glioma, as we all know. This has historically been a clinical diagnosis, and that definition has really been variable and really consists of three parts: imaging, symptoms, and time. Unfortunately, in a lot of clinical trials and a lot of discussions in tumor board, the last two criteria are often dropped, so clinical symptoms and duration. And we focus almost extensively on what the imaging looks like. But be that as it may, these are T2 bright lesions that occupy variably some proportion of the pons, and that have some proportion of neurologic deficits in the kind of classic triad of symptoms there, and operate or manifest in a limited amount of time, whether that's 1 month or 3 months. This has really been supplanted as we've come to understand the biology that drives the initiation and propagation of DIPG, and we now recognize the kind of establishing somatic recurrent mutation in the histone H3 genes, principally the H3.3 variant, but also 3.1 and even more rarely 3.2. And then what's been collectively referred to as histone wild type group of tumors that often have easy hip overexpression thought to molecularly phenocopy the genetic change there. Next one. And then to kind of further complicate this or refine it, depending upon your perspective, we've now updated this based on the WHO classification, where we have a pathologic diagnosis that also incorporates clinical criteria. So it must be diffuse, midline, and K27 altered through a couple different mechanisms. And that has been nice because it expands it beyond the brainstem, and it collectively essentially includes thalamic and spinal cord tumors. But I really want to just focus on DIPG or pontine DMG for the purposes of this talk, because from a radiation perspective, we have much better, although still ways to go, much better defined radiation parameters. And there's a lot more variability as it comes to thalamic and spinal cord management. So next slide. So I first wanted to just give a historical perspective and the clinical impact of radiation for DIPG. I think sometimes this is glossed over, but it's not an infrequent discussion that I have at the very beginning when I meet patients and their families based on such poor prognosis. And it's really been a fascinating experience to go back, when I first started, to really go back as far as I could, try to understand the history, as we often end up repeating it, unfortunately. And you can go back well over 100 years to reports documenting the limited safe surgical options for brainstem tumors. That's an evolving field, of course, which I think we'll hear about later. And then you can see reports emerging really around 100 years from now that document the initial experience with irradiation as a more definitive type of treatment. And then there have been several subsequent studies that demonstrated with a relatively low dose and of course much cruder radiation therapy techniques, you could deliver the radiation safely, and this often resulted in improved neurologic symptoms. And so, as the field has evolved and techniques in both imaging have improved, there have been several reports that have suggested a significant, albeit transient, as we all know, improvement in survival with radiation. And I list here mostly just to underscore the concept that this doesn't come from just one paper, as is often cited. This is a multitude of reports. There's a table that's kind of detailing that. And I will say, of course, from the outset, all of these studies are marred from their retrospectives. Perspective, of course, small number of patients, the clinical diagnosis for these patients, and also some of the statistical analysis. But I put for reference here a paper that I think is a little bit more robust. This is a Norwegian study where they show that in the absence of radiation, so best supportive care, and this is a study that was conducted through the 60s, 70s, and 80s, mind you, you might see a median overall survival of about 3 to 4 months, and that radiation pushes that out, and depending upon your perspective, doubling the overall survival. So wholly inadequate, but I think it does have a role, and that's an important first step when I meet patients. Next slide. So just wanted to lay out some clinical considerations that we think about as we evaluate, when to start and how to start radiation therapy. The first things that I want to look at and really assess is the concern or obvious hydrocephalus. So this has been reported to be about 10% of our patients, and then we obviously have a discussion with our neurosurgeons, who includes Dr. Klimo, about CSF diversion. And I think somewhat uniquely at our institution, we often sometimes consider posterior fossa decompression, which was done in this patient on the right there, where you can see really significant low-lying disease and blocking or crowding of the fourth ventricle in this very advanced DIPG. Also review imaging for hemorrhage. There's a nice study that kind of systematically reviewed this. It does appear a diagnosis in a small minority of patients, but importantly can be a problem symptomatically in about 20% of patients. And then as we have moved, at least at our institution, to more frequently considering biopsy, thankfully, we often have this discussion about how does that biopsy and CT simulation for radiation planning fit. And we've kind of adopted, just based on planning studies that we've done, an approach that if we can see the patient before they go to biopsy, we'd like to sim them, because we don't really see a change in plan quality based on that biopsy. Of course, that depends on the nature of the biopsy, et cetera, and CSF diversion. But I think this helps speed up the process for when they're recovered, which usually they're recovered quite quickly. And then we often have a discussion about steroids. We generally do not start dexamethasone in a patient who comes in stable and not on dexamethasone. There's always concern about the potential swelling and edema that's caused from radiation, but we don't tend to do that. We do, however, tend to keep the dose of steroids stable over the first week of treatment, and then try to taper, as efficiently as possible. And then I would say there's always a discussion about timing, and this is really a delicate balance of, how bad are the symptoms, how bad are they progressing, what type of radiation plan quality do we want, and is there time to really explore that? Can we have a discussion about, does this have to be a sedated procedure? And then I think most importantly, can we hold off for a sec and have a thorough discussion about what clinical trial options there are? There's often a rush, at least from my impression from neuro-oncology, to get patients started as absolutely quickly as possible. And I often cite this paper that established, at least retrospectively, that there was no correlation with time to diagnosis and initiation of radiation with regards to outcome. And in fact, when they dichotomized time here, those that started earlier did poorer, and that's self-explanatory, because those are usually the most ill. So next slide. So I wanted to touch first on radiation modalities and techniques. This was really nicely discussed with Dr. Yock's lecture, but and I fully support all of her conclusions. I would say the one site and type of disease where we may push for photons more consistently would be this disease site. And so I would argue that photon or X-ray based therapy with either IMRT or VMAT is the current standard. This is a volume-based planning process that requires MR fusion to the CT simulation through registration software. Then we go through a process of target delineation, plan development, and optimization, or plan development and optimization with our dosimetrist, and then of course QA from physics. And so that takes time. It's not an immediate thing. It depends by practice institution, of course, but generally on the order of 4 to 5 days. We do get into situations where patients are quite sick, and so we have, at least in my mind, I think about this as, ask neuro-oncology, okay, is this urgent or emergent? And the way that I tend to define that is we need to start the next day or the day after. That's an urgent treatment. I would then opt for at least something that has a little bit more conformality, what we call 3D conformal radiation, or is this emergent? We need to start today. And that's usually a clinical setup with just a pair of opposed lateral beams that irradiate a much larger volume, just because of the imaging uncertainty of where you're treating. And you can see that delineated here in just the schematics below. So next slide. Next, yeah, perfect. So what about proton therapy? Again, we've had this discussion, and I basically sketched out my discussion that I have not infrequently with patients, and my arguments and decision points there. And so, as we saw from Dr. Yock, I think it's an unquestionable, at least dosimetric, finding that proton therapy can reduce dose to collateral tissue, if you will. The issue to understand, though, I think, is that we, as she mentioned, we purposely prescribe proton therapy to a presumed isoeffective dose of photons. That is the clinical practice. And so we wouldn't necessarily expect local control to differ, even if we thought there was a dose-response relationship with this tumor, which I'm really not clear on. And so then the other aspect of that is that photon radiation, which we've been doing for, as I said, over 100 years, is relatively well tolerated with short-term side effects that I'm not sure proton therapy would really mitigate. Most of that is related to skin and hair issues. And again, those are things that would be manifest with protons as well. And then the stark reality, and is always the most difficult to discuss openly with patients, is that the long-term complications are really not manifest in this population, and so long-term late effect sparing is unlikely with protons. We discussed earlier about some of the concerns, mostly case-based concerns about symptomatic radiation necrosis with protons. I do think that there are inherent risks that are different with photons, but I think, again, being able to do that safely at experienced centers can address a lot of those concerns. So I would just say that it's not a uniformity. So I see a lot of referrals from patients who have been recommended to undergo protons, or that come back for reirradiation and that have had proton therapy. I also would add that proton therapy is allowed on the COG on studies, or were ongoing studies for DIPG. So, it is an option. This is just a report of one of those there. So next slide. Okay, so now we can talk about radiation volumes, another favorite topic of radiation oncologists. So I would say from the outset that perhaps the general consensus is that a 1 centimeter anatomically constraint, so not going into tissue or boundaries that the brain would not allow, isotropic, meaning in all dimensions that aren't constrained, that represents the clinical target volume. So this is the concept of a volume that we would treat that harbors subclinical disease, stuff that we can't see on MRI, but we consider at risk for tumor spread. And that obviously encompasses what we can see grossly on MR. And then we typically add a PTV to that when using photons. That's really kind of site dependent, and that's there to establish any kind of day-to-day setup variation. So what's interesting about this is that, as is the case in supratentorial tumors, we have seen over the decades a movement of real shrinking margins. And so if you go back to the older studies, the margins for DIPG were quite large, almost always over 2 centimeters, and often much larger than that. And this also stands in distinction from adult high-grade gliomas, which often have a larger margin, at least 2 centimeters generally. And that's really based on very unique histologic correlations of CT and/or MR findings to really kind of mandate, or not mandate, but to support those kinds of volumetric expansions. So next slide. And while we lack that generally in DIPG and even pediatric high-grade glioma, it is fair to say that based on older autopsy studies, local contiguous spread throughout the brainstem and cerebellum has been the most frequently observed disease spread, if you will, for these patients. However, more recently, skip areas of spread and more distant central nervous system spread has really been increasingly recognized. And I put for reference here two papers that nicely highlighted that. So this is, I think, 6 out of 44 patients where you see highlighted there disease noted in the frontal lobe or distant CNS Mets. and then 2 out of 9 patients in this study showing distant mets. And this has then sparked the conversation, and several authors have put forth maybe we should re-examine radiation margins to consider extended or whole brain or even CSI margins for these patients. But I think it's important, and you can see these in this data here, that most of these studies show convincing tumor progression right in the radiation field that would be covered in the pons, and as I showed you with the margins, certainly into the medulla and midbrain, etc. And that's been a consistent finding for a number of these studies. So next slide. So we were interested in addressing this and really evaluate this in a large cohort of patients of patients with DIPG that were radiographically or histologically defined, because this patient population also included a cohort of patients that were prospectively treated with an extended CTV margin, the hypothesis being that larger margin might lead to better tumor control and maybe even shift survival to some extent. And so what we found was that in this cohort of patients, local failure with or without distant failure represented almost 90% of the cases, and all of them were in the high dose radiation field. And then when we look specifically at the population of patients treated with an extended margin, there was no significant effect on the rate or kinetics of local tumor control, which you can see down here in the cumulative incidence curves. And it didn't shift the pattern of dosimetric or anatomically defined progression, which I didn't show. And then obviously did not shift survival outcomes, either through progression or overall survival, which is indicated there on the right. And so the other thing that we did is really look to see what is the volume of tumor beyond the GTV to try to get a better idea of what the optimal margin would. And in most cases, that extension is really pretty minimal. We're looking at less than half a centimeter, or less than half a centimeter. So we have started to have discussions and really think about this, that maybe it's time to reevaluate smaller margins, or even consider situations where we might not include a CTV at all. And really the utility of that, beyond increasing the speed of radiation planning, of course, is that it may open up less limitations for reirradiation, particularly when we start thinking about optic chiasm or spinal cord constraints in the setting of a second or third course radiation. So next slide. Now we can address dose and fractionation regimens. I would say that conventionally fractionated radiation, generally meaning small fractions of 1.8 or 2 gray over 30 fractions, remain the most commonly utilized regimens in North America, at least. And this is based a little bit on very early studies showed generally lower doses, and lower doses could be delivered with bumping up against dermatologic toxicity. So the way we initially started treating these patients really was limited by the skin toxicity, and so we were just using lower doses. But as the field advanced and we developed megavoltage radiation units, we could establish that we could treat to a higher dose. And so from that, we had several studies that suggested there may be a dose threshold. Again, these are all retrospective, limited number of patients, questionable clinical or pathologic diagnosis. But I highlight one here that really motivates the discussion that higher doses might improve survival. So next slide. And so as we did with adult high-grade glioma, we went through a course of many studies exploring the hypothesis that dose escalation would improve survival. And in the context of DIPG, most of these studies were actually using hyperfractionation, which was the vogue treatment paradigm at that time, which was essentially larger number of smaller fractions over the same time period. So this could be accomplished by a morning treatment and an evening treatment. And this was often even combined with systemic therapy. Unfortunately, as you see from the table here, there were several multi-institutional studies that failed to show an improved survival, and there were some, in fact, that suggested there may be enhanced toxicity, whether prolonged steroid dependency or symptomatic radiation necrosis. So that has fallen by the wayside. I will say it's not just hyperfractionation. There have also been approaches using stereotactic radiosurgery or brachytherapy, brain brachytherapy as a boost to address this question, none of which have gained much traction. So next slide. So now transitioning away from dose escalation and really, or dose, the question of dose, I really would, we can focus on fractionation. So there were some very interesting initial studies from Europe that started addressing this concept of hypofractionation for DIPG. And so this is essentially a smaller number of larger fractions over a shorter period of time. And this is also, this was not unique to DIPG. This was a movement really throughout the field of radiation oncology to consider this as a new type of treatment paradigm. And those initial reports demonstrated similar rates of neurologic symptom improvement, some steroid dependencies, and some survival outcomes, which really motivated now two phase 3 randomized clinical trials that were conducted in Egypt. These were designed as non-inferiority studies to evaluate initially a single hypofractionated regimen relative to conventional, and now has been published 2 hypofractionation regimens relative to conventional fractionation, and that's detailed there below. There were some questions about the first clinical trial, which I've cited there as the second ID number. Essentially, just calling into question, was this really powered as a for non-inferiority, but not arguing the premise that essentially the outcomes were similar. And I think that this has been addressed more thoroughly with a much more robust trial here, again, showing very overlapping survival curves with all 3 regimens. So next slide. So I just wanted to highlight one example which really emerges as perhaps one of the first US studies documenting hypofractionation. This is a study out of the University of Colorado and was really exploring a concept of more extreme hypofractionation. So the details on this is there were 7 patients, all with a clinical diagnosis of DIPG, that were treated in 5 days, and that consisted of 5 gray a day over a week. And this, when you work this out, it would suggest that local control would be potentially compromised. The BED is different from a glioma perspective. Just for sake of completeness, there was a relatively standard margin, and I would say that outcomes were relatively on the low side for newly diagnosed DIPG. But what really sticks out about this study, and I think one that we take away clinically, is that there was a high rate, relatively speaking, of symptomatic radiation necrosis, so about 40 or 3 of 7 patients. And importantly, this wasn't observed in the at least in the Egyptian studies. So next slide. So that would argue kind of there's a lower end of that we need to be careful with. And I did want to emphasize a couple things here. I'll just try to summarize this. What are we doing about this in the United States? And I highlight a trial that I think is interesting that was just recently completed and has been presented, at least in abstract form, looking at 2 different fractionation schemes, conventional versus hypofractionation using 39 and 13 fractions, and the combination of PD-1 blockade. And while the PD-1 blockade story did not seem to shake out, the study did not see obvious differences in outcome by randomized fractionation pattern. And this was a multi-institutional study conducted in North America. So we do get some sense that at some institutions in North America, we can start using this. But I will say across the board, it's rare when I see a hypofractionated regimen used for DIPG. And I think that comes from a lot of different reasons, of course, but there is also reluctance from the neuro-oncology community from a statistical design to incorporate hypofractionated regimens as a standard, maybe not the, but a standard that could be used in trials. It complicates, at least from their perspective, it potentially complicates statistical analysis and reference cohort analysis. And then the other complexity that we find at our institution is we try to motivate almost every patient we can to get on trial with DIPG, but oftentimes now in the paradigm of clinical trial design in DIPG, which often will enroll the patient post-radiation, so you can get radiation anywhere. They try to mandate that the radiation be given, number one, but that it be given in quote unquote standard radiation fractionation. And whatever that means, right? Like standard is what to whom. And so sometimes we get caught in that we feel like we certainly wouldn't want to embark in hypofractionation just to exclude a patient from a trial. Next slide. I did want to touch on a couple things here in terms of the utility of neurologic symptom palliation. So kind of a rule of thumb here is that most studies have suggested that conventionally fractionated radiation improves neurologic symptoms in about 70 to 80% of patients, although we know that this is relatively short-gained. The thing about this is that most of these studies have really focused on after radiation and sometimes for long periods after radiation. And there's really not been a lot of work to see, is there a kinetics during radiation therapy or a dose response to neurologic symptom improvement? And we were really motivated to characterize this because it may suggest alternative RT regimens that we could evaluate in a clinical trial context, and it certainly could help evaluate new combination therapies if there's utility to alternated fractionation, for example, if we're considering immune therapy. And so we undertook a study again in this large kind of cohort of patients with DIPG to document first improvement or worsening in the classic triad of symptoms weekly over a radiation course. And go to the next slide. And so what we found was that for each neurologic symptom category, initial improvements were noted early during radiation therapy and at median doses of about 20 gray, and that's indicated there on the upper left, and then the histograms are on the right there. And importantly, in about 15% of patients, first declines in neurologic status were observed most frequently towards the end of radiation when steroid doses were lowest and radiation doses were relatively higher. And so in doing this, it really highlighted to us that there needs to be a better way to collect and systematically review neurologic function as it is such an important outcome measure for this patient population. And that has really moved forward with things like the nano assessment tool in adult oncology, which is now being currently evaluated in pediatrics and pediatric DMG on clinical trials as we speak. And then it also supported in my mind, kind of innovative clinical trial designs that tend to reframe the utility of radiation, almost thinking of it like a metronomic administration. And this is exemplified by the ongoing Italian study that has this kind of shorter, conventionally fractionated upfront course, hoping for symptom palliation and stabilization. They then would go on to protracted systemic therapy. And then at times of progression, you can do additional courses of radiation. So next slide. All right, I did want to touch on what is probably the most complicated and difficult part in the treatment and of DIPG from a radiation perspective, certainly. I mean, I think just treatment in general, and that is this, really, I think of it as a spectrum: pseudoprogression, radiation necrosis, and progression. I did want to highlight, I think, some important studies that have really established that radiation therapy alone does often result in a radiographic response. Of course, the extent to which is variable, but about 40% in a lot of these papers. There is also a documented pseudoprogression rate of about 10%. But the complexity here is that given just what Dr. Manji discussed, is that the way these tumors grow, almost like a weed through the garden, is just, it makes the attribution of these effects near impossible, because essentially you cannot discern on the MRI level what is tumor and what is healthy normal tissue, or at least normal tissue. And this is really exemplified by a case here on the right, showing a diagnosis 2 months post-radiation, and then 2 months post actual cyst drainage and subtotal resection by Dr. Klimo. So this patient presented, and this is not infrequent, presented with, you know, a massive necrotic tumor, and was quite sick. And you can see, of course, the horrible side effects of steroids as we go through. And shortly after radiation, what we see is just further progression of this tumor necrosis is how I generally refer to it. And so this was resected mostly out of symptomatic management, but also to confirm that this is what we're seeing. And then you see some obvious progression even within 6 months after that. So this is a constant struggle, is really trying to tease this out. And luckily we have recently developed DIPG-specific RAPNO imaging criteria that really incorporates steroid use and neurologic function as well to try to better assess and get a handle of this and have some consistency across clinical trials. All right, next slide. I did want to just touch on a couple things, a couple systemic therapies in the context of radiation. You could go on, and I think we saw some very beautiful work just in the previous two talks, really targeting neuronal activity and also the microenvironment and T-cell therapy. But one of the questions that we often get and that I see a lot of disparities with is about temozolomide. This has been a regimen that we tried per the Stoop protocol now twice, actually 3 times, and those studies are uniformly negative in DIPG patients. The assumption there is that MGMT silencing is just too infrequent to see a benefit. And then I wanted to highlight ONC201. I'm sure an agent that many of y'all are familiar with, but for those maybe not as familiar, this has really been the kind of hot topic on the block in terms of patients with DIPG, and this is based on a pooled analysis of 2 phase 1 studies using ONC201 after radiation, and has led the authors to conclude that this suggests that ONC201 as the first monotherapy to improve outcomes in K27 mutant DMG beyond radiation therapy. However, I would say just based on the statistical design, there have been some concerns that have been raised on reporting bias, immortal time bias, and the relevance of the historic controls, which is always an issue, certainly in phase 1 studies. And I highlight that on the right there, where you see a really wide splay of the time from radiation to initiation of ONC201. And that's just the way the trial was designed, and it really did range and make some of the interpretation a little bit difficult. Importantly, though, there are 2, if you go back just one, there are 2 ongoing trials of concurrent ONC201, so we'll wait to see how these play out. Okay, yeah, next slide, thanks. And I would be remiss if I didn't touch on the concept of radiosensitizers, at least through the lens of DNA repair inhibitors, given this is a radiation talk. We have evaluated PARP inhibitors and have unfortunately, just like in adult GBM, largely fallen flat. This is based on 2 now phase 2 trials looking at veliparib specifically in combination with radiation and followed with temozolomide. Our group has recently evaluated ATM inhibition as a way to radiosensitize, and our lab recently published a report showing significant improved efficacy of radiation when combined with AZD1390, which is a CNS penetrant and very potent ATM inhibitor in a number of distinct PDX models of high-grade glioma. And so based on this data, at least in part, PEP-CTN has been collaborating with AstraZeneca, which manufactures AZD1390, to develop a multi-center phase 1 trial of 1390 in radiation in patients with newly diagnosed high-grade glioma. And I give that as a pitch because this is set to activate next month. So next slide. Not sure on the time part, but hopefully we're doing okay. But I will finish with just reirradiation. This again is a hot topic, and like so many things in medicine, it's a recycling of a topic that if you go back to the initial reports of radiation for DIPG, they describe a second and sometimes third course of radiation. So not necessarily a new twist, but I think much better collated and presented. And this really kicked off in 2010 from a large retrospective review from MD Anderson, which suggested improved survival and response rates with second course radiation relative to a wide range of systemic therapies. And that was followed by a more detailed report from the same group, really looking at radiation variables. And then I want to highlight, I think, what is one of the more robust studies out of Europe. This was a matched pair analysis of patients at first recurrence who were treated with either radiation or best best clinical care or systemic therapy, and again, suggesting an improved survival. So next slide. And then, the question then, of course, becomes, well, what is the right dose, if there is such a thing? And this is a nice study from MD Anderson that has really kind of been the first to prospectively evaluate this. The long and short of this, I would just jump to the bottom, is that it was a relatively limited sample size. They had to close early because of slow accrual. And the dose that ultimately was established in a very unique and I think interesting statistical design has been called into question as to whether or not this is durable enough. But I think that this serves at least as a benchmark for providers to get started with what might be a safe, tolerable dose. So next slide. Okay, we made it. All right. Thank you very much. It's been great, and look forward to questions.
Thank you, Dr. Tinkle. That was, again, a great talk. We'll save the questions for the end. And our final speaker, last but not the least, it's my great pleasure to introduce our own Dr. Benny Iskandar from UW-Madison. Dr. Iskandar is a professor of neurosurgery here at UW-Madison with vast experience and expertise in surgical management of pediatric brain tumors. He's a national leader in the field of pediatric neurosurgery. He also leads a translational research lab that works on epigenetics and central nervous system injury. And today he's going to tell us the role that surgical management plays in this devastating disease. Dr. Iskandar.
Thank you. Can you guys hear me?
Yes.
Yeah, I apologize for my voice, but I have a cold. And so thank you for the invitation, Mahua, and all of you. It's been really enjoyable and educational. I really like the intimate group because it really gives us some freedom to editorialize and discuss things openly. Because this issue, surgical management, particular biopsy of DIPGs, is unarguably the most contentious issue that we've had in DIPG care in the past decades. Second, it remains the deadliest of all brain tumors. We need all hands on deck, and we need to make sure the science is rigorous. I will embarrassingly acknowledge that while the oncologists and the scientists and the radiation therapists have done great science and followed great rigor in assessing outcomes and complications, we have not done the same in surgery. We have not tried to teach the oncology community about what a DIPG biopsy would take, what the real complication rates are, what are the outcomes that we expect from them. So I think you will find that much of what I will talk about today is historical, and I think that's very appropriate. As Winston Churchill said, the farther backward you can look, the farther forward you are likely to see. I will start in the early 1900s to state that these lesions were diagnosed by on autopsy. In the 50s and 60s, there were attempts at biopsying and resecting the lesions, and that was met with high morbidity and mortality. So biopsies were condemned, and in the 1970s, the care was relegated to pneumoencephalograms to identify the tumor as best as people could, but they were not obtaining specimens. So surgery on the IPG was reinvigorated in the 1980s when a few surgeons, especially Fred Epstein in New York, have attempted not just to biopsy these lesions, but to resect them. And this was met with significant morbidity, as you can imagine. So the whole thing was condemned, not just the resection, but also the biopsy. And especially with the advent of MRI, where now the diagnosis was becoming more and more accurate. In the early 2000s, as targeted therapy started to be introduced in various cancers, a clash started to occur in pediatric neurosurgery between proponents and opponents of biopsy. And this coincided with the introduction of CT-guided and stereotactic biopsies, so that they become safer. And then now, as biopsies have become routine, and technology is advancing further, we're in a completely different world. But it took about that many years, since the 1950s, to get here. This was the first paper I'd like to introduce as an example of multiple studies in the 1950s and 60s that showed that surgery on these gliomas is fraught with morbidity and mortality. And at that point, they said that surgical management of pontine glioma should now be limited to the control of hydrocephalus alone. And the tumor itself should not be approached. And that they believe that exploration of the posterior fossa and direct visualization biopsy was unnecessary because the diagnosis is satisfactorily confirmed by ventriculography alone. Now you can imagine what that means when we look at it now. Ventriculography, trying to assess and have good confirmation of a diagnosis of brainstem glioma seems ludicrous at this time. It wasn't then. At least it wasn't perceived to be. The second paper shows the same. 37 patients, they had significant morbidity and mortality with even biopsies. And what I would highlight here is that this was the pre-decadron era, and this is what the authors also highlighted. So you can imagine that biopsying these tumors would be accompanied by significant edema. But importantly, none of these tumors were in the pons. So this is where it became evident that really to be able to be more accurate in the care, you have to separate the tumors based on location at the very least. And this is why. Here are two sagittal images, non-enhanced, T1 images showing a pontine glioma on the right and a medullary glioma on the left, or cervicomedullary glioma. They almost look identical in terms of configuration. I would tell you that the medullary glioma tends to enhance more than the pontine glioma. Nonetheless, at first view, in someone who doesn't know the difference between the anatomical locations, these seem to be the same. Whereas if you take the medullary glioma, that's usually a palicytic astrocytoma, whereas the pontine ones are GBMs. And this is the difference. This is pre-op, this is post-op. It was a curative resection of an intrinsic cervicomedullary tumor that expanded the medulla. When I was resecting this case, I remember this was early in my career, I encountered the anterior subarachnoid space, and I felt very uncomfortable, had them do a wake-up test in the middle of surgery, because I said, how could I go all the way to the subarachnoid space anteriorly and not have a deficit? The patient has no deficits, and he's 20 years out, cured from the tumor. Meaning, just like in real estate, location is very important here. This is the group of papers now that really initiated a lot of the controversies that ensued over the past decades. Fred Epstein and others have tried to radically resect these tumors, and it was met with disasters. And what they found is that the majority of cervicomedullary tumors were low grade and the surgery was associated with low morbidity, whereas the pontine tumors were usually high grade and associated with high morbidity. And their conclusion was that high grade tumors should not be resected. So this is what they said. The only situation when it came to biopsy, the only situation in which a biopsy is meaningful is when it discloses a highly malignant tumor, in which case the biology of the neoplasm will be related to its most malignant component, and the dismal prognosis will be obvious. So even though their practice has shown that resection was highly uh, morbid, they extended their conclusions to include the biopsies. And they said that biopsies are not useful in this case and they might be hazardous. While, on the other hand, they mentioned in their paper that they've identified an occult angioma and one arachnoid cyst of the clivus, all of which had been misinterpreted as intrinsic brainstem neoplasms. Now, obviously, that would not happen now in MRI days, but in those days, when definitive decisions were being made about the care of these really difficult patients, they were basing it on suboptimal technology, suboptimal imaging. So a very thoughtful senior pediatric neurosurgeon that is well respected by everyone I know, Leland Albright, in 1983 published a paper in which he said the reluctance to biopsy brainstem tumors was based on either an unacceptably high morbidity and mortality, either a low predictive value for the biopsy, either the diagnosis can be established by imaging without biopsy, or if the treatment will be the same regardless of the biopsy results, all of which seem very reasonable. And what surprisingly he deduced from this study is that biopsies were indeed of value to identify children at higher histologic risk. Now, these two survival curves show people were biopsied versus people were not biopsied, and they found that the survival times of the biopsied patients was much higher than the non-biopsied patients. But they realized that this was really not the case, that what happened is that the ones that were radiated happened to be the ones that were biopsied. And so what the conclusion really was is that radiation therapy seemed to have improved the outcome of these patients. Nonetheless, Dr. Albright's conclusion was that biopsies were of value. 10 years later, the same author, now part of a CCG study, 120 prospective cooperative phase 1 and 2 clinical trial, which was designed to determine the effectiveness of hyperfractionated radiotherapy, came to the conclusion that operating on these tumors were being performed for insufficient reasons in children with brainstem gliomas. And as yet, no one had demonstrated that modifications in therapy based on the biopsy results contributed to improved outcome. So operations are being performed for insufficient reasons. Now, if you recall, the results of surgery was highly morbid with resections, but not necessarily with biopsy. And indeed, 10 years before, the same group had shown, or the same author had shown, that the biopsies are actually reasonable. They come with reasonable risk and they might have value. But this paper is the one that started really the decades of controversy. So I will talk about it a bit more as I analyzed it, scrutinized it a bit more. It says that I think it's an honest reflection of study results showing that histology did not affect outcome. And that's still true today. The study was designed to study the effectiveness and toxicity of radiotherapy, but not the effectiveness or complications of a biopsy. And in fact, the paper states that tissue diagnosis can be obtained stereotactically with less risk. It did not state that biopsy was high risk. And yet, the oncology community took it to mean that the risk is much higher than the benefit of a biopsy, a problem that lasted more than 3 decades. Despite significant advances in molecular therapy of other fatal cancers, these patients were not given the opportunity to be studied for molecular therapies. And despite significant advances in surgical care and many studies showing that biopsies had low morbidity. So what are the reasons to biopsy nowadays? The first reason is, what if it's not a DMG or a DIPG? And indeed, this is a case report that showed that this particular tumor that looks just like the tumors we care for that we call DMGs was an IDH on H1 mutant, not an H3K27 mutant, M mutant. And the survival of this patient was 9.5 years, unheard of after XRT for these tumors. The other question you ask, what if could there be non-cancerous, non-neoplastic lesions, such as an unusual infection, unusual inflammatory problem that shows up? There are reports in the past that I found, but they're not good enough to prove their contention. So I'm not discussing them here. But that's really the main reason, and for which, for many years, I have biopsied these tumors. The second one is a matter of safety. Is the biopsy not safe? And this is a selection of studies that's representative of the literature. The top 2 are single center studies that showed, well, actually not single center, the one on the right is 23 institutions, one on the right is single center, that showed that there's a 96% diagnostic accuracy to the biopsy and very few morbidities, most of which are transient and no mortality. And meta-analyses that were done on large numbers of patients showed the same results, that 96% accuracy, about 6 to 7% morbidity, and that's usually temporary, with only 0.6 to 1.7% permanent morbidity, and less than 1% mortality. So it is safe. But then when you add the technology that's been ongoing in the past few years, here's stereotactic biopsies, stereotactic techniques. Stereotactic techniques started in the 1950s for functional neurosurgery. They have significantly improved the accuracy of biopsies and the safety of biopsies. And more recently, robotic techniques. In my institution, for example, I use frameless stereotaxy because that's what I'm used to. And my partner who does the epilepsy surgery uses a robot because he's very familiar with this. This is more of an up-and-coming, trying to show you a video here of an endoscopic biopsy of a DIPG. I'm sorry that the video is halting, but the idea is that you can even see what you're targeting. I'm going to move on. I'm sorry that the video isn't showing. Sorry, it's not moving. I'm just going to start it from here. Okay. However, the most important reason to biopsy, certainly nowadays, is targeted individualized therapy, the molecular advances that we've had over the past few years. The advances have shown that these are primarily H3K27M mutants, but there were other molecular alterations that have been found, FGFR1, etc. You can read. Individualized treatment pathways have been published. Epigenetic targeting is becoming more and more common. HDAC inhibitors, BRD4 inhibitors, and some of the histone demethylase inhibitors. Vaccine-based targeting, as we've heard earlier. Tumor penetration by systemic drugs, and convection-enhanced delivery, which if you can do a biopsy safely, you can do convection-enhanced delivery safely to overcome blood-brain barrier problems and broaden distribution. And just to look a little bit about the history of targeted therapy, we can probably go back to the 1890s when Paul Ehrlich suggested that targeted therapy may be a magic bullet to target the disease while minimizing toxicity on surrounding tissues. Now, at the time, this was not targeted toward cancer, but they were thinking more of infectious disease. It was 1998 that the first monoclonal antibody was developed for an HER2 positive breast cancer. And so in 2001, a similar, this time small molecule tyrosine kinase inhibitor targeted CML, Philadelphia chromosome positive CML. And it showed everybody that targeted therapy can be in two forms, monoclonal antibodies or small molecule targeting therapy. And then here's just a rundown of what's happened over the years, all the way from 2001 to 2021. And I would like to point out 2 time points. Between the 2 arrows, this is when the controversial discussions have started among pediatric neurosurgeons. In 2009, we had a meeting at our national conference where it became very contentious, and the room was split into 2 clans. The first clan was pro-biopsy. The second clan was anti-biopsy. And I remember I was at the meeting, and we could very immediately see the difference between the 2 groups. These were people under 50. These were people over 50. It was as clear as day. And that controversy continued for the following 10 years at least, maybe even up to now to some extent, despite all this progress that's been made with other fatal cancers, between breast cancer and CML and others that are being cured with targeted therapy. And we were really sitting in the past. But because some centers started to biopsy these tumors, this led to the discovery of the histone modification, or histone mutant, H3K27M, in 2012. And so that was the direct result of biopsying these lesions. So somehow, while biopsies of eloquent regions, such as the thalamus, the basal ganglia, the motor area, the sylvian region, were considered safe and standard of care, brainstem biopsies were tainted and forbidden by the oncology community and IRBs based on one misrepresented paper. So, DIPG or DMG is universally fatal and remains the leading cause of death among pediatric brain tumors. We must not miss an opportunity to study it. Our patients demand it. emerging surgical and molecular technologies offer hope for the future. However, it's important to recognize historically that we abandoned these patients and stalled scientific progress for 3 decades under the pretense that there was no direct personal benefit to these patients. So from here on, we really have to ensure that our future decisions are guided by sound science. And the science doesn't necessarily just mean that if you give chemotherapy or radiation therapy, you have to provide a prospective randomized study and look at it statistically. But the same rules should be applied to surgical science. What is the morbidity of a particular operation? Are we proving it rigorously, or are we relying on a retrospective study of a single center? And of course, we haven't discussed resection much. Resection is still very hazardous in the pons, but as the world is going toward targeted therapies, I imagine that many of our tumors will stop being surgical in the future, and move toward more medical treatments. So I will end with this quote by Donald Madsen, who's one of the fathers of pediatric neurosurgery. He said, "To our knowledge, no patient with this lesion has ever been cured, and it seems unlikely that one ever will be with our present therapeutic methods." The only issue with this statement is it was about medulloblastoma. Thank you very much.
Thanks so much, Dr. Iskandar. That was a phenomenal talk. Thank you so much. I think you did really a brilliant job in highlighting the complexity of histopathologic confirmation of this disease process, and especially highlighting some of the uncertainty in the literature with regard to kind of what was in the past a moratorium on biopsy to this point, and especially with what we heard in the other talks today, that having that pathology and assessing the specific molecular characteristics of this disease process in order to guide future therapies is critically important. So thank you for that. That was just a great talk. For the participants who are still online, please utilize the chat function in order to ask questions. As was previously mentioned, Dr. Manji had to depart, and so we had done her questions first, but would like to open the floor to the participants and our additional panelists for questions for our second session today on DIPG.
So I have a question for Dr. Madsen, kind of following on what Dr. Iskandar. Now that the targeted therapies came into play because of the biopsies, because we had the tissue. That's what's really is driving that field. And the talk about creating these organoids from these biopsies, these are really great for DMG specifically. So are you still just using the washing the needle and the cells to create them, or do you use some of the samples for creating these organoids?
Yeah, it's a good question, and it calls into some of the ethics around research and what can we use tissue for. Priority number one is always the patient and clinical care of the patient. So we have to put everything towards that's needed there. The needle biopsies are a challenge, right? And there is minimal tissue that's coming out there. And if you're starting to take more just for, say, research purposes, then there's that ethical question. But I think there may come a point where, we clinically do need more tissue to make decisions and to do testing. And I think we're getting close to that point. I don't know if we're quite there, but and there's other opportunities too. There are diffuse midline gliomas where, of the thalamus that are exophytic, and maybe you do a resection, you get more tissue and you'll have more to work with there. But for the needle biopsies, it's a little it's hard right now, I think, to justify pushing volume for research purposes or those, but we're getting creative with how we can do it, I think.
So is this a common, like, for adults, we send them all for like, tempest sequencing or, additional clinical testing that's above the histopath. Is that the same practice for DIPG at this point?
For us, it is, yes. We send advanced sequencing panels on all of our DMG patients. There are trials. I can think of one run out of the PNOC group where patients had advanced sequencing and targetable mutations were identified in many patients. Outcomes were still, we still need to do more work on that, but it did show that many of these patients have additional actionable mutations beyond just the pathognomonic H3K27M. There are for which that we have drugs available to go after. So in our mind, there is a role to do the advanced sequencing to try to find other targets.
Wonderful. We do have a question from our audience as well. Two clinical questions, in fact. So what should the treatment paradigm for DIPG be with a histomutation, H3K27, and a targetable mutation like BRAF or FGFR1? And she notes, admittedly, these are rare, but do exist. Based on anecdotal evidence, seem to have much better outcomes. So I guess DIPG with a histomutation and targetable mutation, how would our clinicians handle treatment for that particular molecular subtype?
Yeah, and Paul answered this too in the chat as well. And there is, this goes back to the strength of the molecular area. There are subtypes of subtypes, right? So there are these MAP kinase altered DMGs that seem to behave differently. They actually even have a seemingly better prognosis than standard. And often are, as Dr. Klima points out, can be exophytic and maybe amenable to resection and often occur more often in the thalamus. So they're a subpopulation of this disease. And yeah, when we come across those, we will treat them with targeted inhibitors of that MAP kinase pathway, whether that's trametinib or any of the available options, molecular options for the MAP kinase pathway.
And the follow-up to that then, outside of the systemic therapies or targeted therapies, would be in which order to attempt those targeted therapies with RT. Should RT come first? Should RT come second? Dr. Klimo had even mentioned these did you, Dr. Madsen, that these are exophytic, consider surgery first. What would be the sequence of events that you guys would treat this with? Dr. Tinkle, I don't know if you wanted to take that one.
Sure. I think BRAF is an interesting story. It's as discussed, a rare population of this tumor, but with very well established drugs, with relatively well tolerated drugs as well. So I think I think we would consider that certainly more frequently. I mean, I think our first instinct here always is what clinical trials are available, because that's the way to move the field forward, at least in my opinion. But of course, these are desperate situations, so you have to be open to whatever might be out there that we could use. There hasn't been a lot of kind of window sequencing with systemic therapy prior to radiation. I would say that it is probably more the norm that folks come in pretty debilitated. And there's, again, like I discussed, often a real push to get radiation started. So it would be selecting a population, I think, that's most optimal for that, and with an agent that I think had a lot of at least preclinical rationale to do it that way.
Any additional input from the other clinicians?
I think radiation is such a standard of care. It's hard to, I think when we come across those opportunities for potential targets, we always start with the radiation just because it is standard of care. And then either shortly after or of course in the relapse setting, that'll trigger use of those agents.
agree with that. Dr. Tinkle, I had one other question that I was really glad you brought up. Just with having been a prior oral board examiner as well in radiation oncology, the question of margins always comes up as we're trying to assess people's safety and knowledge base with regard to treatment of this disease process. And as you raised a very valid point, you go back and look at some of the older textbooks with like 1.5 to 2 centimeter margins around the pons, which is basically treating literally everything in the posterior fossa. I know we've challenged in adult gliomas the concept of margins, even in something that we know perhaps maybe even more of a diffuse process like glioblastoma. But could you, for the residents that are on this presentation right now, can you highlight how you clinically approach your margin expansions, especially based upon what you had mentioned before with regard to some of the diffuse recurrences that you've seen in this disease process as well?
Yeah, I mean, I would say that in discussions, a lot of discussions with neuro-oncologists, basic scientists, and translational folks, like I do think that many times, if not most, DIPG is a systemic disease at diagnosis. But I think the fundamental question is, does changing the radiation field do anything about that? And that's where I'm much less convinced. And I think the point I was trying to make is that invariably, in our experience anyway, and I would say most of the autopsy studies would show, is that yes, while you may have distant disease elsewhere, the irradiated tumor grows back. It is radiation resistant by definition. And so it doesn't make a lot of sense to me to push for, let's say, brain and spine radiation, which you are capped at a dose of, I mean, you can pick it, but subtherapeutic doses. I think anyone would agree to that.
Right.
And then expect that you're going to significantly change the outcome, because I think the natural history is that most folks succumb to disease because of local symptom progression. Not all of them, of course, but most, and not because of a isolated spinal met or even diffuse leptomeningeal disease. So I tend to take a more, I don't know, I wouldn't say conservative. I think it's fairly standard, a 1 centimeter margin. I think there's a lot of folks that believe that you could push that, and that's in fact how our clinical trial was designed when we expanded margins. This predates me getting here, but the data was nice to analyze because it was conducted at least in a prospective fashion. And again, we didn't really see, I mean, I think the most you could hope is if you had an effective local therapy, you were pushing the patterns of failure. So instead of recurrence locally, you were then causing a higher proportion of patients to fail distantly, and then you really have to drum up systemic therapy options. But we didn't see that. And so I think that because of the way that patients are dying is typically local disease.
Thank you. Any other questions?
Dr. Iskandar and Dr. Madsen, I'm curious. So when you get to patients with truly intrinsic pontine diffuse gliomas, what's your preferred biopsy approach? How do you get tissue?
I like the transmiddle cerebral peduncle approach. It's very straightforward. You don't have to worry about any vascular or deep brain structures. Neurosurgeons, pediatric neurosurgeons are used to the posterior fossa. We know it like the back of our hands. And like I told you, we have a little bit of flexibility really there. So in some cases, I've used endoscopy. We have room to work. It works very well. I've never seen anything but a transient deficit with those.
I agree. And say it seems like more often than not, there's a bit of the tumor that always creeps a little bit up that either one side or the other of the middle cerebral peduncle. And you can sometimes you don't even need to enter the brainstem. You're taking actual a peduncle biopsy. So
Yeah.
I think that makes it even safer. But would agree completely.
Cool. Yeah, that's what we do too. And I was sort of curious when you started presenting the endoscopic stuff and the You know, because if you do have to go through the fourth ventricle, you've got to get in somewhere unless it's exophytic. So curious to hear your when you would use.
Yeah, this is endoscopy through the biopsy tract.
Oh, interesting. Okay.
But you know, I don't do it very often like this because you want to just keep things simple. But if there are situations where you're not sure what you're seeing, what I found is when I biopsy, for example, supratentorial lesions, is sometimes there are these low-grade lesions that you can barely, they're small, you don't know how accurate you're going to be, and sometimes following with the endoscope will give you a change in the consistency and the color of the tissues, and it gives me a bit more confidence. But you know, now that we have Freeman stereotaxy that's very, very accurate, it's not as much of an issue.
Yeah, I've utilized the endoscopic biopsy for, you know, if someone presents with hydrocephalus, they need an ETV and they have an exophytic portion that's, you know, just below the floor of the third ventricle, you can grab a piece of it while you're doing the ETV. Done that.
I think you're muted, Dr. Bovee.
Just like I have a face for radio, I don't want to hear my own voice either. So I wanted to thank our participants and of course our discussants for just an amazing morning. I can't thank everyone enough. I do agree with you, Dr. Iskandar, that I love this smaller, intimate venue for being able to share thoughts and you know, challenge kind of standard of care and editorialize a little bit about this. I think it just adds more to the discussion and to the day. I have to give a shout out to the people behind the scenes. We wouldn't be able to do this without the support of Janelle, who is our administrative director for these conferences. And really our saving grace for most everything that happens for today. And then, of course, Caleb for his technical support during our webinar broadcast today. It was just fantastic. Please take the time to, for the participants that are here and even our discussants to fill out the survey review for today's session. We really do read those and take to heart comments in order to try to make this conference better and more meaningful and to add topics that people want to see discussed in a forum like this. So thank you very much. I really do appreciate all of you.
Thank you, everyone.